Good morning, everyone. Before we get started, please, if you could head back to registration and get your translation headsets in case you need translation from Spanish to English. Thank you.
We'll never forget the you let me down, baby. There ain't nobody else. Only you break me to pieces, put me back together. Only you can make this a love game that I play forever. Make a mess of me, you make a mess of all my feelings, and you know it. Ooh, baby, only you can break me to pieces. Your loving a puzzle.
I wanna know your dark side. I wanna know your secrets. I wanna be your lifeline. So I wait for you, wait for me. Wait for you, wait for me. Tell me you're more than just a highlight. Pretty pictures on the outside. I hate to stare at you through these lights. So I wait for you, wait for me. Wait for you, wait for me. Click and scroll, I can't let you go. They say I'm addicted to you. Click and scroll, I can't let you go. They say I'm addicted to you. Oh, oh, this ain't love, no, no. This ain't love, no, no. This is artificial. This ain't love, no, no. This ain't love, no, no. This is artificial.
I wanna know you inside and out. Wanna know what's behind the light. Wanna feel that real love from within. Let me in. I want real love, real highs. You're just enough to get me through, get me through. 'Cause you're officially perfect for me. So I'll wait for you, wait for you.
Up all night thinking,
for being here with us today. We are very pleased to be able to welcome you all to the Fast Track Cities Conference here in Sevilla. Sevilla was the first city in Spain signing the Paris Declaration in 2016 and committing to eliminating HIV by 2030. We would like to thank the Committee of Fast Track City Sevilla for their commitment and leadership on addressing health inequalities and recognizing the right to health for all. Representing the Ministry of Health, the Secretary of State for Health, Dr. Silvia Calzón, on behalf of IAPAC and the Fast Track Cities Institute, Dr. José Manuel Zuniga, the Mayor of Sevilla, Mr. Antonio Muñoz Martínez. Welcome to the Fast Track Cities 2022 Conference in Sevilla.
Alcalde de Sevilla,
Mayor of Seville, President of IAPAC, dear colleagues, good morning, ladies and gentlemen. As Secretary of State, it is for me a true honor to be with you here today at the opening ceremony. On behalf of the Spanish Ministry of Health and Minister Daria, who will be obviously present in this conference this afternoon. She will be coming to the afternoon session. Firstly, I want to confirm our support to local action in health, to the importance of society's action in the struggle against HIV, sexually transmitted diseases, viral hepatitis, and TB. If you allow me, I would like to congratulate the organization of this conference, this international conference, because I am convinced that this very rich agenda for the next 3 days will be an absolute success. On behalf of the Spanish government, I would also like to express my gratitude to the global network with municipalities from all over the world and its main 4 partners, IAPAC, UNAIDS, UN Habitat, and the City Council of Paris. I want to congratulate them all, and especially the new partners. Because along this line, I would like to say today that I am especially proud of the step forward that has been taken in the last few months by many municipalities in Spain to join this network. We have more than 170 Spanish municipalities which have already joined or are in the process of joining, as well as 3 provincial governments, 3 island governments, and 1 man community. Therefore, the local provincial authorities of Spain have taken a firm step forward to support this network. As you know, the Spanish government works hard to achieve UNAIDS goals for 2030, the triple 95. 95% of people with HIV with a diagnosis, 95% of them with a treatment, and 95% with an undetectable viral load. And we do this working hand in hand with the individuals and the patient organizations who play a key role in Spain in the fight against HIV through the NGO Advisory Board. All the challenges are included in our HIV prevention and control plan, together with STDs for 2030, which has 4 main axes. Number 1, prevention. Number 2, early diagnosis, fast access to treatment, and lastly, the management of chronic diseases, because fortunately we are now talking about a chronic condition. These challenges also trigger certain actions aimed at improving the quality of life of people and also at fighting against stigma and discrimination. Because unfortunately, still today, in 2022, we're still forced to remind society that no one can nor should be discriminated for their ethnicity, race, sexual identity, gender, or, of course, serology status. Of course, there is a long way to go, a lot of work to be done, but it is also true that this type of event allows us to have a retrospective glance and see all the achievements since the first AIDS diagnosis was made 40 years ago. And this is all thanks to a joint and constant effort. We have made great progress hand in hand with science, and which are based on hard work and commitment of researchers, clinicians, healthcare professionals, public authority officials, but of course civil society and from the movement against HIV, which have played a catalyst role for social justice. Therefore, action from cities and municipalities is a key link in this chain. And I would like to finish my welcoming address with a wish and words of gratitude. Firstly, thank you. Thank you for your extraordinary commitment with our mission. And secondly, a wish. I want to wish you a seminar which is fully inspiring and productive in this city. The first city in Spain which signed the Paris Declaration, whose mayor is here with us today, and which I am convinced is the best decision they made when organizing this international conference. Thank you very much.
Good morning, muy buenos días. Honorable Secretaria de Estado de
Secretary of State of Health, Dr. Silvia Calzón, Mayor of Seville, Antonio Muñoz Martínez,
governors from various fast-track cities around the world, distinguished guests, and ladies and gentlemen. On behalf of the International Association of Providers of AIDS Care, or IAPAC, welcome to the Fast Track Cities 2022 conference, whether you're joining us in person or virtually. We are proud to host this conference in partnership with the Joint United Nations Program on HIV/AIDS and the Fast Track Cities Institute, and in collaboration with the Stop TB Partnership and the World Hepatitis Alliance. We are grateful for the hospitality of the city of Sevilla and the first city in Spain to join the Fast Track Cities network. We are also grateful to Spain's Ministry of Health for embracing the Fast Track Cities mandate, now being advanced by more than 150 cities across this country, virtually making the country Fast Track Spain. Moreover, we appreciate the participation of stakeholders from across the Fast Track Cities network who are joining us over the next 3 days. We appreciate your willingness to share your experiences and best practices in regaining momentum in your urban HIV, tuberculosis, and viral hepatitis responses, in parallel to efforts to address colliding health challenges, such as the COVID-19 pandemic and the monkeypox outbreak. Since its launch on World AIDS Day 2014, the Fast Track Cities network has expanded to more than 450 cities and municipalities whose elected officials have signed the Paris Declaration on Fast Track Cities. In every region of the world, Fast Track Cities are making great strides in their efforts to reach beyond the UNAIDS 95-95-95 programmatic as well as combination prevention targets, to place themselves on a trajectory towards getting to zero new HIV infections, zero AIDS-related deaths, and as important, zero stigma. Encouragingly on that note, Fast Track Cities have also taken on the challenge of eliminating HIV and intersectional stigma which is a public health threat on par with the human immunodeficiency virus itself. Our calculus for success requires three key elements that are here in abundance: political will and commitment, community engagement and leadership, data-driven and equity-based health planning, and of course, very necessary high-quality clinical and social care and social support. We thus proudly welcome you as elected officials, public health leaders, clinical and service providers, and representatives from affected communities who are implementing the calculus of success. Ladies and gentlemen, our coming together at this conference and sharing ideas, concerns, projections, and stories of hope signals a solid commitment to the values of the Fast Track Cities movement. As a set of guiding principles and a way of working, Fast Track Cities is a force for good and relevant to all settings. I could not be prouder of how far we have come and how far we will go together since we launched this movement with 26 initial Fast Track Cities in 2014. I hope that the next 3 days of conference will help guide us in our ongoing efforts to end urban HIV and TB epidemics and eliminate HBV and HCV by 2030. And on that note, I wish you a successful Fast Track Cities 2022 conference.
Dear Secretary of State from the Spanish Ministry of Health, President of IAPAC, ladies and gentlemen, welcome to Seville. I want to extend special greetings to those of you coming from other cities and countries. Today is a key day for Seville. We have been working for years to prepare this Fast Track Cities conference, which should set the policies to combat HIV, viral hepatitis, and other STDs. And we will do that from Seville. As the mayor, I must confess that I feel very proud, and I feel it's a great responsibility and a challenge. From the Convention of Paris, the cities that concentrate 55% of the world population to combat the challenge of leading the fight against these diseases, and to do it from a partnership and alliance with the association movement, NGOs and professionals, and joining efforts between different authority levels. Our city during this time, as it happens to other cities, has managed to promote a group collective based on unanimity, commitment and mutual understanding, a working methodology which has proven to be very successful over the last few years. Seville in October 2015 was the first Spanish city to join the Fast Track strategy and to set the triple objective 90-90. Seville, as it has happened with other cities, approved a Fast Track plan, a strategy in coordination with other institutions and with the association movement, with three key lines of work: the promotion of health and prevention of HIV infection in all individuals, quality of life and integrated healthcare for people living with HIV, and thirdly, positive equality and effective inclusion of HIV people, key populations, and most vulnerable groups. For the achievement of these goals, the Fast Track Committee was created in Seville, including the City Council, the regional government, the University of Seville, and associations such as Adara, Triángulo, Atenea Médicos del Mundo, and the Community Center for HIV in Seville, various stakeholders. I want to take a break now to expressively express my gratitude to these stakeholders for the constant commitment and efforts to work jointly. We have created synergy between the regional government, the central government, the local government, and the civil society. This strategy has proven to be very productive, and I can show it with data from our city in this international meeting, being very proud, not self-complacent, but proud. 90% of people with HIV in today know about their diagnostic. 98% of them receive medical care and treatment, and 93% of them have an undetectable viral load. Interesting figures that also bring us almost 0% of stigma for HIV/AIDS population. But we must continue working hard and speeding up our work. We cannot let our guard down, not in Seville, not in any other city. That is why we want to reach the 95% as the goal of all these indicators. This World Conference will allow us to take a step forward in a determined and robust manner, extending our work to other STDs. So I want to thank, on behalf of the Society, the International Association of Providers of AIDS Care, for having chosen our city this year, which I think will be a great international conference and a milestone, as well as for the next steps on HIV efforts. Seville is today the center for research, science, and the social view on a big problem such as HIV and other STDs, which is an opportunity that must help us to reinforce our commitment as a society in the struggle against these cities, to launch a clear and robust message that has an international resonance, so that the fight against this disease stays as a priority in the political and institutional agendas. The Seville conference, as it happened in Paris, will be a turning point for the fight against STDs. We will lead the process with a greater commitment from local governments and other public authorities, and we will take on new challenges for years to come. Seville obviously shows its greatest commitment and involvement. We will do our utmost effort to achieve it, working in coordination with other stakeholders and public authorities, and weaving new links and alliances with other towns. The 21st century is the century of cities, and we must build together a future without HIV or any other sexually transmitted diseases. Welcome to Seville. I hope you have a productive conference and it contributes to making inroads to the combat against these diseases. Don't forget about getting to know Seville and about having fun in our city, to those of you coming from other places. Thank you.
Sevilla les da la bienvenida a Fast Track Cities 2000.
Celcom welcomes you to Fast Track Cities 2022.
It's 2022.
Sevilla, una ciudad.
Seville is a city that brings together tradition and modernity. Its history and old quarter, the cuisine, the atmosphere, and the beauty of the river turn Seville into an iconic city. We all know Seville because it's one of the most beautiful cities of Spain. But who knows Seville because of being a fast-track city? On the 1st of December 2024, the Declaration of Paris was signed. Seville became, in 2015, the first city of Spain in committing with this cause. We have professionals from the local, regional government, University of Seville, and civil society stakeholders through NGOs working on HIV/AIDS. Fast Track Seville has created an action plan that allows to mobilize resources in order to achieve the 95-95-95 goals through a multidisciplinary approach, so that we can increase diagnostic tests, other ITS, STDs, and this is all done from these strategies. Thanks to this plan, the city of Seville has better sexual health and quality of life. We're also disseminating about STDs, raising awareness and putting an end to a stigma. The Fast Track Committee is based on equity and accessibility, gender perspective, citizen participation, and scientific and innovation evidence. So sexual health is approached from an integrated perspective, promoting human rights, gender equality, and empowerment of individuals, giving the tools they need to get to know each other and respect each other.
Buenos días a todos y todas. My name is Charles King. I am the Chief Executive Officer of Housing Works in New York City. This morning's opening panel is here to discuss defining the calculus of success for ending urban HIV epidemics. I've been asked to see if we can't make up a little time because of our late start, so I apologize in advance if we don't have opportunity for robust discussion. We have two panelists here in person and one online. I'm sure the people who are here in person would be happy to talk with you offline, and I'm sure Solange would be, and the others would be happy to take your email whether you're here or online. Our first panelist is Dr. Nombulelo Magula, who is the head of the Division of Internal Medicine at Nelson Mandela School of Medicine at the University of KwaZulu-Natal in Durban, South Africa. Nombulelo.
Good morning, ladies and gentlemen, and thank you to the organizers for inviting me to speak here. Thank you for the introduction. So I come from the beautiful city of Durban, and we boast beautiful beaches, and the imposing structure that you see there is our soccer stadium. Beneath the beauty lie many painful and sad stories, which I'm going to share some with you this morning. I'm also going to share some silver linings as well as the hope that lies ahead. So we are grateful for decisions that were taken back in the day to get us onto the trajectory that we are on to get to the end of HIV as a public health threat. Targets were set, and we look ahead to the targets going forward. So for this morning, I'm not going to speak much about the absolute numbers. What I would like to focus on is the stories, is the lived experience behind the numbers. So, Mr. AM is a 30-year-old gentleman that presented to his local clinic and was diagnosed with HIV infection, and he was put onto antiretroviral treatment. A few weeks later, he represented to the same clinic, and this time around, a diagnosis of pulmonary tuberculosis was made, and he was put onto treatment. A few weeks later, he presented in dire straits and respiratory distress, and after testing, he was confirmed to have COVID-19 infection, and he was then sent off to us as we were running a facility that was repurposed for management of COVID-19 for our district. So we put him on to high-tech oxygen equipment and managed his infections, and we looked for other infections that we also considered and confirmed that he had acute hepatitis B infection in addition to these infections. He also had pneumocystis jirovecii pneumonia infection, which we used to call pneumocystis carinii pneumonia, and a bacterial infection, Klebsiella pneumonia, that we also confirmed and treated. In addition to these infections, we also confirmed that he had hepatitis C infection. So altogether, our patient had 7 infections in one person, all at the same time, that we had to manage. He was on oxygen for months, and we also performed a CT scan that confirmed that he also had a pulmonary embolism, which was a complication of COVID-19 infection, and he had bronchiectasis, a complication of the tuberculosis that he'd had previously that was incompletely treated. In terms of the risk factors for all of these infections, what I'd like to highlight is our cultural practice. In our context, if you're sick, the first person that most people will go to is a traditional healer. And what the traditional healer will do is they use blades to make scars to administer treatment. So that will be the first port of call, and many infections are transmitted. And then we have the living conditions that are fertile ground for spread of these infections. Vaccination in the adult population in our setting is also quite low. So that's one story. Another story is that of a 44-year-old woman that had been living with HIV infection from 1997, and had been on treatment, and in 2012 discontinued treatment. When she presented to us with COVID-19 infection, her CD4 cell count was 66, and in addition to COVID-19 infection, we also found her to have pneumocystis carinii, giroveccia pneumonia, community-acquired bacterial infection, and we also confirmed tuberculosis infection. So when COVID-19 set in for her, with not being on antiretroviral treatment, she had all of these other complications, opportunistic infections complicating. In addition, she also had pulmonary embolism. So when we asked why she had discontinued treatment, her response was that she actually didn't know that she had to take this treatment for life. Then we have a 23-year-old woman that presented also to her local clinic. They made a diagnosis of COVID-19 infection, and they sent her to us for management. When she arrived, she was literally at death's door, and she needed ICU, but ICU said, please do your best, and we did our best. On careful examination of her, we also found that she had fluid collection, which we tried to aspirate while she was on all of this complicated, sophisticated oxygen equipment. In the process, we caused a pneumothorax, which is air escaping out of the lungs, which we then had to remove using a tube. And this tube is placed in between the ribs. In the process, we're able to collect this fluid. And on investigation of this fluid, she also had tuberculosis. So we treated her for all of these infections. She was in hospital for more than 3 months on oxygen. Her story, her backstory is that she actually contracted HIV infection at sexual debut. She was initiated onto treatment. She actually didn't know why she was taking the treatment that she was on. The last story that I'm going to share with you is that of a 33-year-old mother that was unemployed, presented to us with what looked like a stroke, a weakness of one side of the body. She also had been living with HIV for some time and had discontinued treatment. Her CD4 cell count was 19. And her CT scan, you can see there, this mass, which was ring enhancing, and as you go into the deeper cuts, you see this mass pushing the midline of the brain with ventricles dilated, which makes it unsafe for us to do a diagnostic lumbar puncture. And so in this context, we would consider infections such as toxoplasmosis, tuberculoma, cryptococcoma, and she also incidentally tested positive for cryptococcal antigen on the blood test, serum cryptococcal antigen test. In addition, we would also consider lymphoma presenting like this. We don't know much about COVID-19, so we don't know what the role of COVID-19 is in this particular setting. So we treated her for all the infections that we could possibly treat. Now, the commonest risk factor that we see often as a result of people that start treatment and stopping. The commonest usually is stigma. Stigma in its many different shapes and forms. Food security is another big problem. The common thread in the stories that I've shared with you just now is also the poor conditions of living. This is the sort of setup that most of our patients find themselves. And so COVID-19, that's the silver lining I referred to, appeared to have opened up access to care for these patients, for us to manage this complicated TB and HIV. We are quite grateful to our leadership in the province because they actually repurposed a facility, planted lots of resources, and allowed us to be creative. And we were then able to open up care with all the training of the staff and equipment that we could use. We were able to then open up access to these patients that otherwise would have had to go through the normal stepwise access to care. And what we did is that we leveraged digital technology. Using a digital app, nurses and doctors that work in primary healthcare centers, in district facilities, regional, even all the way up to quaternary, we used this digital app to connect with everybody, and everyone was then able to bring patients forward into care, and were able to alter the outcome for many of the patients that presented through the pandemic period. So those are the stories beneath the numbers. And it's going to be vital that we find solutions to these stories behind the numbers if we are going to get a meaningful success to get us onto the targets that we have set. So this picture is a curve of the actual numbers behind the targets that are set. It's not modeling data, it's absolute data that is used for modeling purposes. And this data is that of women that attend antenatal care in our facilities, public health facilities in South Africa. And this particular slide is numbers in our province of KwaZulu-Natal, where you can see prior to, it's been very well done. Prior to 1990, you can see that we did not have women attending antenatal care living with HIV infection. By the year 2004, when we started providing antiretroviral treatment in the public health sector, the numbers had skyrocketed to 40%, and we are still at about the same number. So if we are going to make a difference, we have to start with this population. And you can actually see from this figure here that KwaZulu-Natal is the leading province. And when I speak in any forum, in my country, in my province, in my city, I tell everyone that if, as KwaZulu-Natal, much closer to attaining the goals that have been set, because there is not another country in the world that is close to the numbers that we have in South Africa of people that are living with HIV. But what is the underlying story? The underlying story, this is a picture when you fly into my city, Durban, this is what you see. There's the ocean over there. Closer to the sea is Durban, the city. And as you move away from the city, you move into the suburbs and you move into the townships. This is a picture, typical picture of a suburb area. As a black child or black person, you would not be found anywhere there without permission, because it was law. Black people were not allowed to be in that area. And this is a picture where black people that were in the city were allowed to live. This is the township where I grew up in. And apartheid is now a thing of the past. But what remains is the lack of resources. So during apartheid, as black people, we were banished to barren rural land, and now we are free to live where we want to live, but the resources are not there, and hence you find people living in these circumstances hoping to access resources and a better future for themselves as well as their children. This is our reality. So when HIV took hold, families were separated because of these economic issues. Fathers were working somewhere else. Mothers were looking after children alone. The HIV epidemic set foot under those circumstances and wiped a whole entire generation of parents off the face of our country. Imagine your 14-year-old, your 12-year-old, not having parents to guide them. That is the situation that we find ourselves. The stats that I have shown you, 60% of those pregnant women, it is 60% in KwaZulu-Natal, it's unintended pregnancies. We need families to be guiding the children for us to be able to deal. That is the starting point. And because of this separation by law and separation that led to lack of resources, we are living in a state of poverty, extreme inequality with those that have and those that do not have, that are not able to access the necessary education, the necessary health, and so on. That leads us to where we are. As a consequence of this, we then have a problem of violence that prevails in our country, that dates back, that is ingrained in our DNA because of the slavery and the brutal treatment that we experienced as a nation through colonialism. And that pain remains, and so the violence prevails. And we, every day, the stats are put out of gender-based violence that ranges from rape all the way to killings. And to put this into perspective, that anybody is at risk, in my own graduation class at medical school, 2 women that I graduated with, shortly after graduation, were brutally killed by their own partners. So that is the pain that we live. And it is in getting to all of these problems and dealing with them that we will find and the solutions, the calculus that will get us to the targets that we have set. In the context of the COVID-19 pandemic, we must address the disproportionate burden of HIV and social ills on women, children, and the vulnerable groups, with women being at the center of this as caretakers, as the one that guide families. We have to address poverty, we have to address stigma that underlies and perpetuates the problems that are preventing us to getting to the targets. Hope for the future. This picture taken in May this year with our Deputy Minister of Health when we launched an amazing program that seeks to address, it's literally a manual, it's a roadmap that seeks to address all of these problems that I have shared with you. The strategy is for non-communicable diseases, but it looks at non-communicable diseases with a goal to extending life expectancy. What this national strategy plan is built on, it is built on the framework of the target setting and all the intervention that have been employed towards ending the HIV epidemic. So it looks at a very integrated approach to addressing all these social ills. We're hosting a conference at my university where we bring in all the districts, where we are going to be unpacking this, a goal of extending life, a long life for all, because there is no time to be dealing with one pandemic at a time, with one epidemic at a time. So the focus of the conference is going to be implementing the strategy on an integrated, person-centered, multi-sectoral response that seeks to address all of these social ills and problems that are keeping us from meaningfully making the targets that we set. And so with that, I thank you very much for your attention, and I'd like to acknowledge all these people that are listed here. Thank you.
Thank you so much, Dr. Magula, and I think that was a powerful presentation made ever so much stronger by presenting your calculus through the lives of people who are actually living with HIV. So I very much appreciate that. Our next presenter is going to be coming to us from Europe. That is Tom van Benthem, who is Senior Policy Advisor on Public Health for the Public Health Service of Amsterdam in the Netherlands. Tom.
Good morning, everybody. Well, there's our big shoes to fill, but I'll try anyway after that powerful presentation we just had. My presentation will be a bit different. I'm a policy advisor, as Charles already said, so I'll be talking more about policy and about how far we've come in Amsterdam. And don't get me wrong, we're very proud of where we are today. And I'd like to share that with you and also about our calculus. A little outline of my presentation. I'll share a few numbers with you. As said, I'm not the researcher, but we have people with us who are very good at those figures. Why we aim for zero, a small overview of what we're doing, of course our challenges, and how we work together in Amsterdam. And I'll try to keep it as short as possible. Here you see our curve of a number of new HIV diagnoses in Amsterdam on the bottom and the Netherlands on the top. And here you see our figures are going down, and are going down slowly but steadily. And here you see, and that's what I also wanted to know your local epidemic, the new diagnosis for men having sex with men on the left, and men having sex with men combined with people with a migrant background. And here also on the left you see exactly where our program started. We started way earlier in 2014 with the help of Gilead on a trial basis. But since 2018, I think it is, or 19, I'm looking for 19, see, I have my colleagues in the room. There's been a bigger trial on PrEP. It's still a trial in the Netherlands. Unfortunately, we're not happy with that. We lobby about that all the time. So if somebody's watching from the Ministry of Health from the Netherlands, please do something about that. But we have a large program outroll in Amsterdam, and we see the effects in our numbers are working very well. Here's our continuum of care for everybody. As you see, we're almost on the 95 targets. We are 1% short in the middle, as highlighted here. But here you see the continuum of care for men having sex with men, which are even better numbers, which are on the 97, 95, 96 levels. And as I would like to add, we have mainly 4 target groups in Amsterdam, of which 2 target groups no longer know any HIV transmission, and that's people who inject drugs and sex workers. We have succeeded to eliminate HIV transmission altogether there. So that's why we are ambitious. We are getting close, and we are aiming for zero. Our city council has approved the new policy for HIV, and it's getting to 0 new HIV infections in 2026. We are ambitious, so we're trying to set the goals as high as possible to keep the continuum going, or keep the momentum going. And why do we do that? Why do we aim for zero? Well, we want people to be able to live a life that is happy, healthy, and free. We want to eliminate the risk of transmission because, as we all know, HIV has a major impact on public health. We have specific groups that are still at an increased risk in Amsterdam, and we're trying to focus our policy to find those groups and target those groups specifically. We have roughly about 300 people living in Amsterdam that still do not know their HIV status, and those will be the last 300 people that keeps us from getting to the 100% in the first section of the 90-90-90 targets. And we try to target those groups as specifically as possible. So we also included in our policy that we now have, we are not looking for needles in one haystack, we are looking for small haystacks and then needles in those few pockets of haystacks in the city. And we're doing our best to target as best as we can. Also, people acquiring HIV are often not because of medical reasons, but because of non-medical factors like stigma, taboo, discrimination, or lack of access to healthcare, or simply not knowing how the healthcare system works in Amsterdam. And of course, our core values as a city of liberty and freedom to be yourself gives us a special responsibility to eliminate HIV in Amsterdam. These are our key priorities from that policy I just mentioned. Expand the possibilities for testing, including self-testing. That's the one thing we need to work harder on. And community-based testing. To make large-scale use of PrEP possible, I already mentioned that just a few minutes ago. We need to quickly start treatment of everyone diagnosed with HIV. Most importantly, we need to tackle the stigmas, and that's also why we're here. We'd like to share Amsterdam's experience with the rest of the Netherlands. A few of my colleagues, for example, will be presenting tomorrow the city case on Amsterdam. That's tomorrow afternoon. And on the people who inject drugs, there's a poster presentation today, I believe, this afternoon. Of course, we have challenges like everybody else. The biggest challenge is stigma in our situation. This can range from stigma around HIV testing, discrimination against people living with HIV, stigma about living with HIV itself, a stigma within certain communities, and stigma amongst professionals, not to be forgotten because they are still there, also in the Netherlands, and we strongly feel that we should tackle those stigma as soon as possible because we believe it's unacceptable to have stigma working within the healthcare system. From our mayor's speech at the AIDS 2018 conference in Amsterdam, reasons for not getting HIV treatment are almost never medical reasons. They are bigotry, homophobia, religious fanaticism, unjust economic systems, and indifferent governments. Our weapons are not just medicine and evidence, but more important are ideals of freedom, open-mindedness, and social progress. I still think that's a very powerful statement, so I'd like to share that with you here. These are a few pictures. You may know it, you may not know it, but this is the Canal Parade. It's a yearly parade. This is our mayor, Mayor Halsema, in the middle, in the white dress, surrounded by the deputy mayors. During the Pride, we celebrate the possibility to be yourself. But we also, it's not just the Canal Parade, it's a full week. It's at the first week of August, so if you ever have the possibility, don't just come to the parade, but come to the whole week because there's a lot of things to be seen and done there. Also, in the parade is, for example, the police force, the military. This year, the highest military chief, would you call it, I think, was also on board of the parades, which shows we're still making progress on tackling stigma. And this is from a community-driven, community group, which of course are also represented during the Pride. And now I have to wait for the new. And we also see more and more, which we're very happy with, people with a migrant background also joining the parade. This is a boat with Moroccan people on them. People from Morocco, sorry. The challenges, also very important. The last mile on the road to zero new HIV infection poses the biggest challenge. As I said, we need to find those small haystacks in small pockets within our city, trying to locate those last few people that still don't know their status. And that's also the second bullet, finding it difficult to reach and underserved individuals not aware of their infection. And we need to further optimize comprehensive prevention programs and their uptake to motivate people to take appropriate measures to prevent getting infected with HIV and thus working on your sexual health. Lastly, but certainly not leastly, I'd like to highlight the cooperation that we have in Amsterdam between medical, and that's HIV treatment centers or GPs, with the city administration, where I'm at, the public health department, but also with community groups. We have, since a year ago, we started a clinic for trans people who had difficulties accessing the regular healthcare in Amsterdam, and we started a clinic driven by the community and helping out there, and there will be a presentation about that Thursday, yes, sorry, checking the room. And that's all I had to say from Amsterdam, so I still hope we made up a little time, and Solange, you'll have enough time left because she's online with us.
Thank you so much, Tom and Benthem. Coming from New York State, where we have defined ending the epidemic as getting below 800 new cases a year, I must say I am impressed by the audacity of the city of Amsterdam to go for 0. That's truly remarkable. Our last presenter this morning will be coming to us through Zoom. She is the Executive Director of the International Treatment Preparedness Coalition Global and hails from Johannesburg, South Africa. Please welcome Solange Baptiste. I know that she is on Zoom, so I'm not sure who's responsible for projecting her.
I see myself.
Oh, yeah.
There she is. Welcome, Solange.
Okay, great. I was talking to myself for a minute. Can you hear me well? I'm just checking in.
We can indeed. You're coming through loud and clear.
Thank you very much, and it's exciting to be here, although I can't really see the room. I am very happy to be among the opening panel this morning and to be part of and to be invited to the Fast Track Cities in 2022. If someone can bring up my slides, that would be great. I actually hail from Trinidad. I am from the small island in the Caribbean, but I sit in Johannesburg in South Africa. So just wanted to say that. Just waiting for my slides to pop up. There we go. I think I see them. Now they're gone.
So,
I'll wait to see.
Hold on one moment. We're not seeing your slides. So again, whoever's responsible for projection, if you could help us, that would be appreciated.
No problem. These are some of the teething issues of doing hybrid meetings. So we'll get there in a few minutes.
Okay, we've got it. Go ahead.
I'm happy to do that, but I don't see them.
Oh dear.
I can watch my slides on my own, or I could also just share my slides, whatever the organizers would like me to do.
Why don't you share your slides with the folk who are running the show and just indicate when you need them to advance them for you?
Okay, I could try to do that.
And my apologies, everyone. I think this is our first remote.
Are you seeing the slides?
Yes. Yes. Take it away.
Okay, wonderful. So you see, all the time that I gained from Tom, I've lost now getting the slides up. Okay, so I was reflecting on the title, which is, again, defining the calculus of success, and thinking, my goodness, when was the last time I did calculus? Something comes to mind about differentiation and integration, and yes, I did it, but can I remember it? So really trying to remember what calculus means, and it's I think when I Googled the literal definition of what calculus is, it's sort of the method of calculation or reasoning. and so the process by which we define success. And like the previous speakers, I'll be talking about this from a community perspective. So looking here, defining success in ending HIV through a community lens. And so what comes to mind, I advanced a slide. Did it advance?
Yes.
Just, okay, great. What comes to mind when we think about our targets and what success looks like, I'm sure is what everyone thinks about here, which is our targets. We moved from the 90-90-90 targets to the 95-95-95 targets, and 200,000 new infections globally and zero discrimination. But if you think about this from a community perspective, I don't know if that's what the average person or recipient of care would think about. The story for us usually starts here, which is at the point of need or through the lived experiences, as has been said before. And often we're struck with this sort of scenario, which is not really what success looks like. It's one of those things that we have to address, which is come back tomorrow, we're out of stock. What really actually happens when you go to collect your medicines. I wanted to also then frame the starting of this with a question to the audience. So in 2016, the United Nations Political Declaration on Ending AIDS set the fast track to end the epidemic by 2030. By 2030, what % of service delivery should be community-led? Do we know? Do we have an idea? This should be easy for everyone. I'm sure people are speaking in the audience. The answer is 30%. 30% of all service delivery by 2030 is to be community-led. I thought that was interesting for us to pop back up into our memory of things we agreed to. And the question I have then is, what is our current level? Are we even able to track that very well? I know we had stumbling blocks around the definition of what is community, and so this has been very difficult to track. So let's see where we are, and if others have information about that, that would be great to know. Under fast-track cities, we have different contexts, different results, and I'm sure this is just a refresher to you. And so it's really important to remember that cities are not a monolith, and the idea that you can talk about one city, but even within the specific city, as Tom just explained, I love it. It's not a needle in a haystack, but very small haystacks and then specific needles that you have to be looking for. So unique gaps in the cascade, different groups that are being quote unquote left behind, various resource constraints, the socio-political and economic factors. And then we have these universal questions around how we identify those gaps, so the how, the calculus of doing, who is collecting the data, whose reality counts, whose metrics count, and how do we hold all stakeholders accountable. And when we say all, we really mean all, the decision makers, the donors, the government, healthcare workers, etc. So, this whole idea of, you measure what you treasure. Only the things that you really value and really that you want to find out are the things that you properly track. So when it comes to monitoring urban HIV epidemics, the question of whose reality counts is important. So if you asked a donor what they would be monitoring, or government or healthcare provider or an academic institution, perhaps you would get a very different answer, or several overlapping answers, but not always what recipients of care would be asking for. And so we can identify city-specific gaps and measure progress towards ending HIV and ensuring accountability via community-led monitoring. Just one example of a community-led intervention, which I think has sort of been touched on our previous panel examples. So putting communities first and looking at community-led monitoring, and as a refresher for those who aren't familiar with this, it is there's a full-on strategic initiative under the Global Fund. It is funded by the French 5%. It's funded under the COP guidance for PEPFAR funding. Community-led monitoring is something everyone in the room should know about and should be happening in every city. It's not community-based, so who is leading is really critical. The indicators are not set by outside entities. They're really determined collectively and led by the need of communities first, so that you can get the whole data story, not just one perspective, and which is usually the service provider. Routine recurring data collection, so not a snapshot at a point in time, but really getting data across a period of time, and you're tracking the same thing, sort of like how you would do it for your blood pressure. And data is owned by communities, so not necessarily housed And I know those things can be tricky, but really needs to be owned by communities. And the end goal is not to collect data, but really to improve a particular issue, which is the pain point that has been identified. And here's the community-led monitoring model. For those that aren't familiar, I won't go through too much detail, but education, so know the standards, know what it is you're supposed to be checking on. I think about the case studies of the persons who were presented by our first speaker in KwaZulu-Natal, and what actually happened in terms of education and understanding what services should be provided by the healthcare system. And then collecting the evidence, engaging in an advocacy, and which they're mutually reinforcing. Because of time, I won't go into too much detail, but this is at the risk of oversimplification, community-led monitoring in 6 steps. So you figure out the need, you identify your indicators, you track that with proper quality data assessments, you figure out what does this data now mean, you speak to that issue in a community consultative group or some other name you want to give it. It's analogous to those who are familiar with the CCMs at the Global Fund, where you have a group of people that meet together with their different stakeholders, and then you actually work on the problem and solve for change, and you co-create those solutions. And the important thing to note here is that success is at the end here. It's not about collecting the data and just figuring out what the problem is, which is sometimes very sexy for academics. So how can CLM help fast-track cities end HIV? It will give you sort of the missing piece of information, the recipient of care perspective, and making the data really whole and rounded out. I'm going to go through very quickly some examples of wins that have been achieved through community-led monitoring, and looking here at, a framework that has been used across many different ones, which I think is quite helpful if you look at availability, accessibility, acceptability, affordability, and appropriateness. So CLM in action. This is a citizen science data project that happened that's currently going on Malawi and South Africa. You can see here, if you think about accessibility, looking at COVID times, when COVID first started, COVID negatively affecting the quality of care and disrupting referrals processes. So in Malawi, looking at viral load test results took more than 3 months to come back to persons before the pandemic, and this worsened to 63% during the peak period, but since improved to 32%. So what is important here is that what I'm going to show you are examples of data that comes from community-led monitoring, robust on the qualitative and quantitative side. So trying to get to the nuance of the why, but also being able to give you robust numbers behind the stories of what has been coming out, which some may call anecdotal. And in South Africa, we looked at viral load suppression, and we saw that there was a decrease in viral load suppression when comparing pre-COVID and post-COVID. Because I have many slides, I'm not going to go through, and these will be available, I'm sure, on the website for review. We talked about availability, the adaptations in COVID era to facilitate access to essential medicines. We looked at multi-month dispensing. In Malawi, 6 MD of ART was scaled up from 6% pre-COVID to 31% after COVID, still far from the new guidelines, and we've been pushing for this for a long time, but we can see here that there were barriers to scale up around healthcare worker attitudes, as well as some issues around stockouts, for example. And then we look at MMD for PrEP as well, seeing that dispensing was inconsistent, although PrEP was scaled up from 0% to a high number. What that looked like over the period was very inconsistent. And moving across to Guatemala, we look at availability, maintaining consistent dispensing with stockout alerts in Guatemala, and really seeing that ITPC, Latin America, and the Caribbean was able to do this monitoring and inform the Ministry of Public Health and Social Assistance around the alert system on their medicines. And you'll see that in the second bullet, exactly what they were looking for in the 6 medicines. Appropriateness, tracking gender-based violence, and also acceptability around key population-friendly services, both in Malawi and South Africa. And we see here that the community data collectors, or the citizen scientists themselves, have become powerful agents of change within the facilities, getting back, feeding information back to healthcare workers, especially following up on actions. And then affordability, we looked at it from a user fee perspective. This was one of our famous examples that was with Ambassador Debbie Birx back in 2019, the COP planning meeting there. The community-led monitoring data really highlighted at a granular level what was happening at the clinics, and that there was still user fees being paid, although this was not supposed to be happening, and a circular was issued by the Ministry of Health, and so we can see the removal of these user fees happening. And then making optimal DTG-based regimens affordable in Brazil, for example. We know that through the work of communities and looking for, shaping the quote-unquote market, the price is often an issue, and it's very different from the cost. And so in terms of the creation of demand and price negotiations, we were able to move that down to $548 per patient per person per year, and which is an 85% reduction. And here we're looking at the price of DTG being decreased from $1.02 to 85 cents per tablet, generating an estimated 67 million cumulative savings in 2019 to 2021. So just looking again at the role of communities in being able to shape things, not just at one specific level, but really using that affordability, that quadruple A framework that I had presented earlier. So looking at insights and accountability wins from CLM, just to recap, we're looking at program improvements, mapping and responding to COVID-19 and addressing structural issues. You see all of this happening. We see key takeaways in applying CLM to ending HIV, defining success through a community lens, whose priorities are we monitoring, who is leading the monitoring process, and communities bringing unique insights to pinpoint gaps to potential solutions. We also know that the CLM work, and particularly Malawi and South Africa, were able to generate savings, as well as being able to put into their COP and Global Fund processes for PEPFAR and Global Fund based on the data that was generated from community-led monitoring, which is really significant. Ensuring accountability, so not just data collection. Is community data readily available? And if it is, are you learning from the community data? Is community data considered credible as other forms of data? And is the end goal to generate data or to create change? So those are some key questions. Wrapping up now, saving lives and reaching our targets. So these are familiar to us, especially those who work and see the UN AIDS targets that we have. So we have on the prevention side and the treatment side, and this is dependent and kind of tracking back to what Jose had said at the start, the three critical components to getting to the calculus of success. We really need science, we need innovation, we need partnership, political will, we need community leadership. So we need resources and informed decision making, but we need reliable and whole data picture. And we know that you can hide actual inequities if you have these aggregate numbers at a country level, or sometimes even at a wider urban city level, and you do not get to the granular subpopulation data. And you can think that you're achieving these targets, but you're actually not. And there's quite a lot of evidence that can show you this. So using our traditional methods will only get us thus far. And so we really need to make sure that we ensure that the demand side of the data story is shared. And so the last question I'm asking here is, how will we know what we need to change? How and where will we know we need to intervene before 2030 in urban cities? And it's really impossible to do that without the supply side and the demand side, so the user, the recipient of care data. Our traditional M&E systems do not adequately integrate community data as part of our data story, and so really want to put it out there that community-led monitoring is a critical health innovation tool in our arsenal. And these are some more resources on community-led monitoring. Thank you very, very much.
Thank you, Solange, Baptiste, for that tour de force around the world focus on community engagement. If you don't mind, I'm going to impinge on your break by just a few minutes to take a couple of questions. So if you do have a question, there are mics in the center aisle. And Doctor, I want to start by asking you a question while others think of what they want to ask. So you described a situation in KwaZulu-Natal where many people are already experiencing severe chronic conditions before they receive their diagnosis, where one woman you described had no idea that ARVs were for life, and another didn't even know why she was taking the ARVs. In that kind of setting, how do you see ending HIV as a public health threat?
Thank you very much for that question, yes. And we started out right in 2004 when we introduced antiretroviral therapy with a program of action that ensured that everyone was counseled thoroughly. We ensured that everyone had the necessary support, they understood there were lessons that had to be taken, and even clinically. So I showed the one patient, the first one, who had all of these infections but was started on antiretroviral therapy before all of this assessment was made. So back then, all this work went in, and only at the end of all this process did we then say that, yes, you are now ready to start treatment. Unfortunately, what has happened over time, the pressure to get to the targets has also had this negative push to get people to do things very fast. We have a policy of test and treat, which doesn't give people time to go through all of this counseling. And the pressure also comes, if I may say, is that there's a fear that if we don't produce the numbers, we're going to lose the funding. And so the pressure mounts to get the numbers, but in the process, we are losing the time to engage and counsel and provide support so that everyone that starts treatment knows exactly what it's about. They've taken time, they've even taken time to think about it and consider the sort of support they need. So yes, we need to get to the targets, and yes, the time is running out, but we also need to pause to make sure that everyone is given enough time to take things in and has the necessary support.
Thank you, thank you. And Solange, let me ask you, you did this survey of a number of urban settings. I wonder if you could talk about what urban settings you see who are doing well the job of engaging communities and inviting communities to take responsibility around provision of prevention and care.
I'm not sure if there was a survey that we did, but we have been working with many cities and countries. I would say that across all of them, I think every city and country is saying that they want to and need to work with communities. I don't think that anyone at this stage in the game of trying to end HIV is working without community engagement. The quality of that engagement is, I think, what we need to bring into question, and the quality of the care that is being given, as was just spoken about, is what I think needs to come into the light now. And how do we actually measure that quality as we try to fast track our success? I would say that we have very good examples within the sub-Saharan African region. I see lots of access being, if I call a particular city, then they'll say, why don't you call that other city? And then that city itself has pluses and minuses. But I can say that I have seen quite a lot of success. I think when you bring in the side of community-led monitoring, which I think is sort of risky because many people get a little scared at a government level. You know, what is this community data? What will it say? What will it bring out? It can be risky, but it's really important to say that if you come with a collaborative, co-design, co-creation approach to solutions as opposed to finger pointing, we see that there's a lot of acceleration towards change. And I would say the city of Sevilla is really the most shining example as we're back here now today speaking.
Thank you so much. And then one last question directed at Tom. I wonder if you could talk a little bit. I know that in Amsterdam, the gay and bisexual community is fairly well organized, and there's a lot of networks of communication. How has that worked in terms of addressing HIV, both from the prevention and treatment side among people who use drugs, sex workers, immigrants who come in without ties to an established community?
It's a good question. I think on the whole, of course, yes, it helped. And it also helps, for example, that we have community leaders that are, for example, running a club that really take ownership and say, okay, well, we need to work with the community. For example, we do, it's just a small example, we do sexy side parties. They are especially for people who have just arrived in the Netherlands or are with a migrant background, have never done or are afraid to go to, or afraid or feel not welcome. So we organize special evenings, or the club does that, and we organize testing or counseling if that's wanted. So it's not in your face there, but if you want to do some testing, that is possible. And that's just one little example of how we work together with the community at the venues where the community wants to be. And I'm also giving this example because MSM with a migrant background who have just come to the Netherlands or maybe are there for a longer time but don't feel welcome at regular MSM clubs, they do feel welcome at this venue. So we keep working together with the community to tailor as much and as specific as we can do and as they can do, as communities take their own responsibility to take care of everybody involved in a community.
Thank you, thank you. So, I think we've done the best we could as a panel to get us back on time. So if we don't start on time, it's all you guys' fault, even if I did cut your break in half. Thank you so much.
Is your head spinning too? My heart stopped when I first saw you. My world stopped spinning. Now my world revolves around you. Did your heart stop when you first saw me? Did your world stop spinning? Does your world revolve around me? Me too. Me too. Should I stop where I'm falling for me? Is your world stop spinning? Is your head spinning too?
Hola, ¿tú me oyes a mí? Yo estoy saliendo por el inglés. Soy Pepe... perdona. No. Espera, Concha.
Did your world stop spinning? Does your world revolve around me? Me too. Me too. control. I keep telling myself, but I don't wanna let you know. Is this what we become? Strangers on the run, looking for something, chasing the sun. All those days trying to find a place where you won't make them just be alone, be alone. All those nights lying by your side, like it's a vibe, feeling it shine under your spotlight. Like it's a vibe under your spotlight. That's the way every day goes. Looking back, I know we started falling. We were falling in love, yeah. Took my heart and you rode off. Was I feeling never enough for you, baby? When you left me chasing you, chasing you. Trying to find a place where we can be alone. All those nights lying by your side, like it's a vibe, feeling it shine under your spotlight.
can feel it somewhere inside, haunting. Like a drug I keep on wanting. There's a love that fits so perfect, it's hard to believe. There's a reason I can feel my heart stop beating, and the air gets tough just breathing. I'm alone, but I'm still feeling like someone's with me. It's strange, I know, but I feel like you're here with me, like chasing ghosts. I know you're out there. Time is unfair, 'cause I know you're out there somewhere, patient, waiting unaware, feeling like your grip might slip too soon. But I'm running, chasing speed and gunning. I'll be right there all of a sudden. I feel your heartbeat lead me straight to you. It's strange, I know, but I feel like you're here with me. It's like chasing ghosts. I know you're out there.
Creo que faltan tres. Creo que faltan tres. Sí, en las tres primeras. Yo también lo he pensado. Total. Muchas gracias. Good morning. Welcome to the high-level panel at the Fast Track Cities 2022 conference. Our topic for the next 2 hours with our distinguished panelists is focused on realizing the human rights to health for migrant population. While the panelists for session 1, they are already sat, allow me to place the topic into context to frame our discussion in the limited time we have for such a complex topic. Most countries of the world have agreed on incorporating migrants into national HIV plans, but there is an economy of scale and difference at play in a world exhausted by COVID-19 and other health challenges and with health budgets in perpetual contraction. In this context, what remains to be done to prioritize migrant health? And of course, what are our collective priorities for an HIV response that is inclusive of key populations and groups of the margins? Migrants are shown to be an effective part of local economic life. Socioeconomic security helps to counter multiple vulnerabilities, including, of course, hostility from host communities. This, we know, is a good antidote to increase exposure to HIV. Many examples exist where this is working well, but have we created an enabling policy environment? And how supportive is our labor legislation? What of HIV in the workplace, of health insurance and access to quality service for all? We also often hear of an area approach to migration. In other words, an approach this is not focused on individual population groups, but on all who reside in a geopolitical boundary. But the dynamics of demography in urban spaces are challenging at best, so how can we overcome? And what are the models we need to use those exemplars from current practice? We will try to answer as many of those questions in short time that we have this morning as we approach this issue of migrant health with honesty and through the lens of political leaders and subject matter experts, including, of course, from Ukraine, where mass migration of refugees sadly became a humanitarian issue as a result of the war. I now wish to start the first of the 2 one-hour sessions by introducing our first panelist, Ms. María Encarnación Aguilar, Deputy Mayor, Sevilla, Dr. Thabida Kamulwesh, Deputy Governor of the Bangkok Metropolitan Administration in Thailand, Mr. Delroy Williams, Mayor of Kingston, Jamaica, Mr. Austin Abraham, Mayor of Gaborone, Botswana, Dr. Eamon Murphy from the Joint United Nations Programs, Mr. Andriy Klepikov from the Alliance for Public Health in Ukraine, and Dr. Meg Doherty from the World Health Organization. Thank you all for being here. I would like to start with María Encarnación, Deputy Mayor Sevilla. Hola, buenos días. A migrant person who generates a sustainable income will go far in reducing health risks and improving both personal community health, including, of course, in relation with HIV. So in the context of Spain, and more specifically Sevilla, how can this happen and what role can cities play in relation to stimulating economic opportunity for migrants?
Hello, good morning. Please allow me to share a few ideas that I would like to highlight. To do that, I will read them because I don't want them to forget about any of them. So thank you, and hello to the other members of the panel. It's a pleasure to share this panel with you. Firstly, I want to highlight the role that the City of Seville and the Seville City Council have played to tackle HIV. We are a city which is fully committed from day one to approach HIV as well as any other STDs. To that end, we were the first city in Spain which signed the Paris commitment together with ADARA. ADARA is an association, an NGO that helped us and sort of like pushed us to go along this way at the City Council that we have been working on since 2016. So if you allow me, I'll go into the subject matter after giving you the context of Seville and what we have done so far. Why are we here in the fast track in Seville? I think Seville has played a key role in the efforts that we are discussing today. And I just wanted everyone coming from abroad to have a context of the background of the city of Seville. One of the strengths that Seville has had is to find a consensus amongst the different authority levels at regional, local, and national scopes to work together to achieve the goal that we are talking about today. So I was to strengthen the importance of this multi-level strategy to organize alliances with other governments in our fast-track committee. The NGOs operating in Seville are a part of this committee, and they are actively involved in our joint work to achieve the 95-95-95 goals. For us, it has been absolutely strategic to forge these alliances to succeed in this project. In Seville, Andalusia, and Spain, we are very fortunate to not having barriers to healthcare as it happens in other regions and countries in the world. Here, migrants arrive and they have equal rights in our healthcare system, fully consolidated rights. Doctors Without Borders, Adara, Triangulo, and Atenea, they are 4 NGOs operating in Seville, and they are also international, and they support migrants, and they are working in the field with migrants to help them be introduced in our healthcare service system. So they accompany them to the healthcare service, they work on chronic pathologies, they work on psychological and emotional issues, and they help migrants to have a fulfilled life in Spain. I want to highlight the work that these NGOs carry out, as well as the amazing public health care that Andalusia and Spain have as well. And our healthcare professionals work really hard to achieve this 95%, which is a key target. The City Council of Seville collaborates in these endeavors by having more than 150,000 euros that we give to these NGOs to carry out this field work I've just mentioned. The NGOs fund programs to act upon the goals that we have in the Fast Track Committee. Additionally, we are very aware of the social change. These migrants do not only need a medical diagnosis and a treatment and a follow-up, but also they need a social support, emotional support. They need to fulfill the circle to be full citizens in our society with all rights. So there is a broad scope of social services, both in Andalusia and Spain. Social services work really well, with many programs aimed at not only employment, but also social support. Language is sometimes a barrier in health centers, but these NGOs manage to overcome the language barrier really well, and they help migrants with language issues. The city of Seville, although we do not have local competencies on employment, the city of Seville has a specific plan called Integrating Seville since 2016, aimed at providing advice to migrants to help them find social and labor integration. Most of the beneficiaries of our work are vulnerable people with problems. They are sex workers, prostitutes with low social and economic level that come to Seville running away from wars or famine or other types of problems in their countries of origin. But I want to tell you that even though we still have a long way to go, a lot of work to do, because everything we put in this box of vulnerable people needs a lot of work. It's never enough. We always need to give them more, because there are many people who need us. And Seville has the has 3 very poor districts in our city. So we need to continue working on social inclusion and integration. We need to have social services that are really strong and a public healthcare system. So I think this is the formula. Public social services, public healthcare, and this is the best formula to help these people who come with social problems as well as STDs, HIVs, and other pathologies that come hand in hand with their status. So we need to strengthen healthcare services, social services to help them. Spain is a country which is committed for equality, for public services. Spain is a country that hosts migrants to make sure they have effective and realistic integration. But I don't want to be self-complacent, as the mayor said this morning. We have a lot of work to do. Indeed, initiatives such as Fast Track and us joining forces here today to discuss this matter and to reach productive conclusions and good practices that we can apply at home, I believe is a great undertaking. So I'm fully available to work with you.
Dr. Tavira Kamovesh, Deputy Governor of Bangkok Metropolitan Administration. The Metropolitan Administration is ahead of the game in implementing the Health for All approach, which means realizing the human right to health for all migrant populations in relation to HIV and its co-infection. So could you please elaborate on the efforts that Bangkok has made to facilitate the HIV and other health services for migrant population?
Thank you very much. First of all, let me thank you for the organizer and thank you. And the host of the event that inviting us and to have a chance to present in this conference. And before I get into what I want to speak, let me report some of the number that my team want me to speak. Other than that, I cannot go back home if I don't report this to the conference. When you said that Bangkok is actually take the lead of doing this 95, 95, 95, to our attention is that we are trying to cope with a lot of what we actually call migrants. And to be honest, within Thailand, we have about 5 million migrants in Thailand that they are significant to the economy of Thailand as well, because a lot of them is actually the workers and a lot of them is actually helping us in terms of boosting up the economy as well. Within Bangkok itself, approximately about 468,000 migrants documented, which means that with the undocumented, we are achieving as much more of the number higher than that. And some of that we know, we have the group of the volunteers that are actually working with these migrant groups, and also the other numbers that we don't know of. COVID-19 has given us a lot of opportunity to create and actually welcome back trust to these migrant workers. And for the past 3 years, we have a lot of numbers of migrant undocumented and documented walk in and out into our public service centers. And a lot of them is actually already in our care of the program. So with all of that, I can say that a lot of migrant workers and families actually has been taken care of from Bangkok coverage system. As you also know that Thailand has universal health coverage for all migrants. And this is actually under the policy of Health for All. And with this kind of policy, the migrants, workers, actually with the documented, they have 2 kind of insurance system already backing up in terms of financing and investment from the government to this kind of group. So we have both Social Security and from the Ministry of Labor and also the Migrant Health Program from the Ministry of Public Health. So with this, we cannot claim that it's only solely BMA kind of effort, but it's actually multi-layers of the government and administration that are helping on this, as well as the migrant women who's actually received the ANC. And I think from our report, 18 out of 19 HIV positives that actually receive ARV treatment, and we have 0 babies in terms of infected with the HIV. So by that, all of this progress is being done through a lot of the program in Bangkok itself. So if you put me to talk into what exactly is an effort to the progress of it, I would put it into 3 different kind of progress. First, I would say all the collaboration through a lot of multi-sectoral stakeholders all over Bangkok. And when I said multi-sectoral stakeholders, that also include multi-layers of the government, every ministry that concerned in this, BMA itself in terms of agencies, as well as CSO, civil society organizations. We have plenty of foundations that actually come with us and do a lot of work on the ground, especially those in volunteers, migrant health volunteers, which is also met with the IOM. It's trying to afford into making all of the instruction and accessibility into health guidance to these migrant workers, especially in HIV, in different languages, especially ASEAN languages, because most of the migrant workers is actually underlying into the region, coming to Bangkok itself as a center of business. The other factors that I would actually aim for is a good leadership. And when I said good leadership, it's not per se like a discourse of good leadership with cliche in terms of that meaning. But leadership in what I mean is that even if our administrations is claiming to position for the past 5 months, I cannot claim that all of the progress that Thailand has made from 2014 until this year, it's actually under every administration that they put, what's shown of that is budget. For the past 8 years, 4 and 4, the budget has been increased twice as much every 4 years. So by that, the budget is already invested into this kind of public service accessibility to all of the migrant workers. Last but not the least, I think the society itself, we grab this opportunity from Thailand and as well as Bangkok as a metropolis. The society itself has a lot more awareness as well as empathize kind of approach to actually understand both sides of the migrant workers who have HIV as well as the workers, the rest of the workers that actually not identify as of HIV. This kind of blending and understanding more of this kind of HIV community has encouraged the society itself to be more understandable and working together in terms of doing a peer, doing a group consultation. So I think that's all come to what BMA has achieved. However, we also intend to get to 95, 95, 95 within another 4 years. So we aim at 2025 to achieve at 95, 95, 95, and hopefully zero or ending the HIV within 2030. If you ask me what challenge that BMA has left, if you go by number, we are achieved 95, 90, and 95, which means that we have some problem and gaps at the second goal. And from what my team has told me and I saw, I myself went to the public center without my team acknowledging it. And I realized that a lot of people who walk into a clinic, there's actually not the people from the surrounding community. So basically, at the second goal, those people have lost from the system. One side of it, I think the trust level to the agency and the public service, we still have gap to do. And to do that, we might be able to, BMA has a very good data analytic in terms of assessing to these people, but we have not really do analytical assessment in terms of when we said need-based, when we say demand-driven, when we said client-centered. The word client-centered, BMA can do more. Trying to understand the segment and the loss of the people, we're going to fill that 5% of the gap with matching program. One of my team has just actually introduced that to me. And I think with this matching program, we can have peer group. We can have them pairing up and trying to actually get them back on track from the 5% losing that actually we cannot accomplish. So by all of this, I think we have to create and come back with the safety economy together with the safety health, because these migrant workers, documented or undocumented, they will come back to Bangkok very soon. And it will be an increasing number for the next year onward, because the economy has to be boosted up. And they have to come back to work after the COVID-19 that they actually pledged out of the Bangkok. So by all of this, I think we still have a lot more to go. So thank you for saying that we're taking lead and we are ahead of any fast-track city. But I think until we reach the ending or the number 0, then I can come back again and claim that leading position. Thank you.
Thank you so much. Let's continue with Mr. Delroy Williams, mayor from Kingston, Jamaica. The link in healthcare access from immigration status was shown to work overall at the height of COVID-19 pandemic. Such a policy intervention eliminates a critical barrier that denies migrants access to essential health and social service. So how can we avoid political backsliding towards reforging links between identification papers and accessing health services, including for HIV?
Good morning, mayors and members of this panel and attendees. Madam Chair, there are approximately 280 million migrants across the globe. I mean, they can be in different categories. You have migrant workers, you have displaced persons, and various other categories. But the total number is about 280 million, which is representing close to 4% of the global 7.8 billion persons of the global population. That's not an insignificant number. In fact, that is a very significant number. If you were to put all migrants together in a country, it would be the fourth largest country in the world, following China, India, and the United States. And so the point I'm making is the number of migrants across the globe is significant. So in protecting global public health, you have to properly address the health needs of migrants. That's something we cannot ignore. And another important point would be also the protection of global public health is also a very key component of global growth and sustainable development. So it is incumbent on us to work towards, to continue discussions and towards collaboration and coordination to protect to cater to the health needs of migrants. I would also say, for example, let's look at Kingston, for example. The urbanization is increasing in a similar way. Migration is increasing across the globe. Urbanization is increasing. If you were to look at Kingston, we take the number of persons moving into Kingston, not from outside of Jamaica, but from within Jamaica, but from rural areas. And they move into Kingston for various reasons, better life, and but for various reasons. As the city leaders, we could not say that we're only catering for the health needs of the residents of the municipality. That would not be in keeping with our goals for economic development, sustainable development, and prosperity. In fact, in order to grow the city and the city's economy, one would have to cater to the health needs of the entire population and not just your resident population. Similarly, if you project that kind of thinking on the global stage, it's a similar kind of thinking. States are obliged to protect or to address the health needs of their entire population and not just their citizens. And there are various reasons why. We know the reasons. Also, the COVID pandemic would have taught us some lessons that I believe we would have already known. The lessons of the interconnectedness and how it is important that we protect, in protecting global health, that we address health needs of various groupings and vulnerable groups across the world. The final thing I would say is, in Kingston during the pandemic, there were various vulnerable groups in the city, for example, homeless persons. We had to set up temporary shelters for homeless persons with all the COVID protocols in place. But we moved beyond that. We also started and completed during the pandemic a transitional center for homeless persons, a modern transitional center for homeless persons. We have also started a program that employ homeless persons as environmental wardens, and their primary purpose is to ensure that they protect certain spaces that are very critical to the city, and they have been doing a wonderful job. So I will end by saying that I believe on the issue of the health needs of migrants, that there has to be a common platform, a common framework, which means that you have to have continued discussion towards collaboration and coordination. Thanks.
Thank you very much for sharing your ideas with us. Mr. Austin Abraham, Mayor Gaborone, Botswana, thank you for being here. Our thinking about migration still dominates much of the public policy response in relation to health planning and budgeting. So to paraphrase the International Organization on Migration, we need to grow our conceptualization of migrant health, bring it down to earth, and make it real. So what is the evidence we need to change mindsets in city halls around the world and work towards inclusive urban health policy in relation to migration?
Thank you, Moderator, mayors, deputy mayors, directors and executives of different organizations, members of the media, ladies and gentlemen, buenos dias. Botswana is a perfect case study that provides the evidence to support what you would have said. We take this opportunity to invite you to Botswana, which is known not just for its diamonds, but for its sustainable wildlife tourism, including the famous Okavango Delta. In answering the question, our experience in Botswana has shown that a paradigm shift in the way we look at migrants and investing in them is needed and goes a long way in reaching epidemic control. Ladies and gentlemen, I'm sharing the Botswana case study on implementing of treat all strategy based on an AIDS investment case study. Botswana is a landlocked upper middle income, which takes pride in contributing 2/3 of the AIDS response through domestic resources. We have over 300,000 people on treatment, with an impressive viral suppression of 98%. The leadership of our President, His Excellency Dr. Mokgweetsi Eric Abetsu Masisi, and the First Lady, Ms. Neo Jane Masisi, has embraced the international evidence to lead the response with the highest political level commitment. What was the situation before? In 2016, the government of Botswana adopted the treat all strategy. Very soon it was found that non-citizens, immigrants were getting excluded from ARV. These non-citizens were 22,000 and made up 7% of the total population. Excluding the immigrants was contrary to the treat for all strategy. Collection of evidence. The government commissioned an AIDS investment case study, which to answer questions such as one, who are concerned non-citizens not able to access ARV and why should they meet? How much would it cost and the total economic benefit? And what would be the cost of inaction towards AIDS response goals? First, why would we be concerned about not treating non-citizens? It was shown that non-citizens were less likely to know HIV status and less likely to be ART. In terms of risk of HIV, 1/3 of people in Botswana aged between 15 to 35 years have multiple concurrent partners, having many sexual partners at the same time, and one person can in fact have the people in their sexual network. Second, what would be the cost of treating non-citizens? The government of Botswana needed only an additional 1.2% of annual spending on the ART program between 2018 to 2030. That is 1.4 million USD for non-citizens, added to 103 million USD for citizens. And the total economic benefit was that for every $1 invested in treating non-citizens, Botswana gets $8 in return. Thirdly, what would the cost of inaction towards aid response goals by 2030? The study showed that if non-citizens are not treated, Botswana cannot achieve 95 treatment targets. That is, percent of persons living with HIV are aware of their status or on treatment and virally suppressed by 2030. The study also showed that if non-citizens are treated, the country will reach 95 treatment targets ahead of 2030. For the goal of elimination mother-to-child transmission, that is EMTCT, with unmarried non-citizen mothers not receiving treatment to prevent vertical transmission, it would not be achieved. Ladies and gentlemen, so how did the government of Botswana respond to this compelling evidence? The government of Botswana invested in treating non-citizens through the Treat All program, demonstrating its commitment and innovation in the AIDS response. And what has been the result? Remarkable achievement of AIDS response goals. Ladies and gentlemen, I am happy to report that Botswana has reached 2 major goals in the AIDS response. Botswana has achieved UNAIDS 95 targets. That is, persons of people living with HIV aware of their status on treatment and virally suppressed at the level of 2020. Botswana is the first high HIV burden country to be certified for achieving the silver tier on the path of elimination of HIV by World Health Organization, which moves it closer to eliminating mother-to-child HIV transmission. In conclusion, ladies and gentlemen, based on the evidence from AIDS investment case, Botswana has shown that investing on the total resident population and a likely additional investment of 1.2% per annum. We gratefully accept the invitation to join the First Cities initiative. I affirm my commitment as the Mayor of Gaborone City Council to share our experiences with other cities. Ladies and gentlemen, muchísimas gracias.
Muchas gracias. Thank you so much. Let's continue with Dr. Eamon Murphy, UNAIDS, Geneva, Switzerland. Thank you for being here. In highly developed countries, migrants will be found in resource-constrained areas of the city. For example, African migrants in Western Europe who are living extremely vulnerable lives at heightened risk to HIV and other disease. Should the discussion be less concerned with migrants and more about inequality of healthcare? And does the situation facing migrants not simply compound an already existing problem that requires maybe a more global solution?
Thank you very much. Buenos dias, colleagues. It's a privilege to be on the panel and at the Fast Track Cities event. All protocols observed in terms of introductions. The sessions, including yesterday, looking at the work of cities as diverse as Kingston, Lagos, and many others, already has set the scene for many of the issues that I'm going to touch on around the issue of migration. But because, as we know, and we've just heard from some of the other panelists, migrants are moving constantly and for different reasons, and often with the economic imbalance are at greater risk of HIV. And we've heard from 2 delegates, the city of Bangkok and just now Gaborone, about the importance of including all in the responses, and many other successful city programs and national programs are addressing the totality of the population, not separating. There are examples like the 30 baht scheme in Thailand, where many of the migrants are neighboring countries, right? But they are treated the same as other citizens. And we've just heard the same in the last speaker, the Mayor Gaborone. But of concern to us all is the issue of forced migration, which from all accounts is, of course, increasing globally. Some of the migrants into Thailand are forced migrants, not just choosing for economic advantage and change. Andre will talk to us, obviously, more closely to home around the issues affecting Ukraine and forced migration to other parts of Europe. So we're not just talking about African migrants, there's a whole range. And as this type of migration is unplanned, unwanted, and abuse of human rights. Of course, ending AIDS, as we've heard from many of our speakers, is really built on ensuring a rights-based approach to the protection and the best possible healthcare for all, not separating different parts of society, either even within our domestic populations. There's always inequalities. Some, be they in urban areas or even rural areas, there's differentials in access to care, access to treatment and other services that are needed. And so these inequalities are at the heart of what need to be addressed, not just for HIV, but successful health programs. In situations of mass upheaval, the rights are often lost, and it, of course, jeopardizes our collective goals for obtaining the Sustainable Development Goals and universal health coverage. The Global AIDS Strategy, 2021 to 2026, clearly demonstrates, in matter-of-fact terms, how to realize and sustain rights for all, inclusive of refugees, asylum seekers, internally displaced people, and migrants of all sorts. And with 2025 fast approaching, the benchmark year for ending AIDS as a public health threat, positive and proactive action for migrants is urgent. We've heard some really good examples from the panel, but we've got many other places with a long way to go, because in many places we're actually seeing a resurgence of HIV and the impact of COVID and other public health issues, and then compounded by civil disruption or natural crises are impacting on programs. The economics, as we've heard, are also critical. It's a motivator for migration, but it's also the challenge for people who are migrants. Their choices are limited, and many of the migrants then seek accommodation in overcrowded, congested areas, which can be in the urban or peri-urban settings, and they're often more informal in their nature, and obviously with the worst health outcomes and quite often the least access to care. The consequence is, of course, compounding the vulnerabilities for migrants and their host communities, and are often a hotspot for HIV. Yet to survive, the people in these situations often have to take risks they might not take elsewhere. And they are being denied opportunities for their health-seeking behaviours. So this reality is what we all need to collectively address. UNAIDS works with co-sponsors for the integration of HIV into policy and plans of what's called the Humanitarian and Development Peace Nexus. So when we're looking at issues of forced migration or large mobility of populations, these areas are both the natural development, as we heard from Thailand, of the economic growth of a setting, but then we've also seen the impact in countries of the forced migration of people, and that's the humanitarian aspect. So for UNAIDS and our co-sponsor family, and it's great to be on the panel here with Meg, WHO, one of our key partners in this response, a nexus approach provides the opportunity to call for structural change in the cities and the peri-urban settlements. And this needs to be realized through both national development plans, but also the city plans themselves. And during the course of our Fast Track Cities events over the next few days, we're going to hear some really exciting examples. And I see the mayor of Quezon City from the Philippines sitting in front of me. Great work being done. So we have so many opportunities to learn from each other. The UN, through its country team, is an active partner in supporting these development plans. Nexus thinking also calls for inclusivity of migrants and all social groups on the margins of society in both short-term humanitarian responses and the long-term development gains that we need to look at both. And as emphasized in the Global AIDS Strategy, we need to promote innovative forms of healthcare that are both community-driven and patient-centered and support a One Health approach that is relevant and contextualized to meet the needs of all persons, regardless, for example, of political status, of acceptance in society. The issues of stigma and discrimination, of course, are one of the greatest forms of inequalities that keep people away from the services they need and have a right to. The Fast Track Cities program will demonstrate the effectiveness of bringing healthcare to populations in resource-constrained spaces, and we advocate, in partnership with our co-sponsoring UN agencies and the national partners who are here today, at the highest level, and in the implementation of community action for tackling persistent inequalities for all. It has to be a true partnership of the communities, of governments, of our partners within the systems, our healthcare, our social protection colleagues, all different parts. And that's where the cities have a unique advantage of having them closely coordinated. To end AIDS, we must adopt an inequalities lens for AIDS, for tuberculosis, for malaria, for many public health issues. Migrants and residents alike must never have to decide between health, food, or shelter. We need to be able to provide the services because migrants benefit all countries. UNAIDS makes no distinction in population cohorts and endorses the principle of the minimum standard of care appropriately established, quality assured, and delivered in an efficient and effective manner with the full participation both of the providers and the users of these services, including migrants. And we've seen this being done in informal settlements, in peri-urban settlements, and in cities itself, as well as the hosts, and importantly, those in transit, who are an important migrant population who need access to services. And that's challenging a number of the countries in Europe, to go back to your question, and this is a big issue that needs to be addressed. So this is where we need to collectively raise our voice, because this is where the change will take place, particularly in cities. So to end inequalities affecting migrants, we can end AIDS as well. Thanks very much.
Thank you so much. Mr. Andriy Klepikov, Alliance for Public Health from Kiev, Ukraine, thank you so much for being here. Let me say and justify war on Ukraine tragically provoke a man-made refugee crisis, forcing many Ukrainians to flee to neighboring countries as well as countries in other regions of the world. I would like to ask you first, what are some of the lessons learned in managing the refugee crisis? And also, what would you say are some of the do's and don'ts of managing mass migration in a humanitarian way that takes into account chronic health needs, including, of course, in relation to HIV? Thank you.
Thank you. Buenos dias. I came here directly from Kiev, the city which was so heavily attacked as many, many other cities in Ukraine yesterday, with attacking civilian sectors, kindergartens, apartment buildings, playgrounds, and many more. Not only in Kiev, but in many, many cities all over Ukraine. This is an example how Fast Track City is reacting to extraordinary circumstances. Could you imagine that everything you planned in a normal life, just in a moment, turned upside down with the war coming to your country? It's terrible, but this is an illustration how we can sustain even in extraordinary circumstances. I'm here bringing our national flag as a symbol of resilience and fighting, not only for Ukrainian territorial integrity, but for human rights, for civilized principle of coexistence, fighting for all of us. Fast-track cities were affected the most from the very beginning, from 24th of February when Russia invaded Ukraine and started bombing all major cities. Our lessons are that mayors play a key role being on the front line with people. We see our president addressing the nation every day from start of the war. we see our mayors, Vitaly Klitschko, Gennady Trukhanov, Boris Filatov, Alexander Vilkul, also being with people, with the city dwellers, also every day being in daily contacts. It's critically important to demonstrate leadership in these extraordinary circumstances. Another lesson is partnership. In the situation of war, something doesn't work. And we see the situation when a pharmaceutical plant producing methadone was destroyed. So government couldn't easily procure medicines. We did. By we, I mean civil society organization, like Alliance for Public Health, my organization, Network 100% Life. When it comes to the delivery, procurement of medicines, international organization came, like PEPFAR, Global Fund, WHO, UNAIDS, and helped to procure. When it came to the delivery, again, civil society stepped in. It's very important to rely on each other in these extraordinary circumstances. And I'm happy to say that in addition to municipalities, to the government, civil society and community is also backbone of the HIV and TB response. The investments done in these sectors paid off a lot. Talking about migrants, we have both internally displaced people and migrants. Since the World War II, it's the largest move of the population in Europe. We have 7.1 million internally displaced people, 7.1 million, and 6 million war refugees or migrants. So 13.1 million Ukrainians moved, and moved sometimes in half an hour, packing the backpack and just escaping from the war, not prepared absolutely. So even those who appeared in other cities, they're also moving back, returning, and so it's very dynamic process. So in this situation, also combination of civil society support is critical. When we reconnected with the patients from Mariupol, the city also signed Paris Declaration, and where 90% of the buildings were destroyed, same as Aleppo in Syria. Patients contacted firstly not medical doctors, but social workers. The people they have the largest and more significant trust with. So a few lessons at the end. So one is having mobile services. When your population is mobile, your services cannot be statical. So we use mobile clinics, we use them in the deoccupied territories and the situations where hospitals are destroyed, still providing life essential services to people, including IDPs, internally displaced people, and migrants. Second, go digital. People use their phones to track the situations, the news, the same for medical services. We served over 11,000 migrants in other countries, even in developed countries like Germany or Hungary, but people don't have access to services because of the barriers, because of the lack of documentation, registration, language barriers. So these applications like Help Now was critical to continue treatment. And another thing very important is to rely on civil society and community, because as I said, this proved to be reliable and effective mechanism in the wartime, in the time where usual connections collapsed. Finally, I would like to say everyone who supported and keep supporting Ukraine in this situation. We are displaying the QR code for further support because we are receiving more and more requests from cities, and we are also helping and looking to help because of the upcoming winter. Winterization is critical. When we talk about human rights, it's also important that even fundamental rights like right to live, right to eat, right to not to be frozen are under threat. So in order to address this, we need more funds to address humanitarian needs. We used to work in HIV area, but if someone is asking for bread, I cannot say, sorry, I have only condom for you. Yeah? We need to find a way to provide bread to those who are hungry. So that's why resources are critically needed to address humanitarian needs, to address needs to prepare for the winter. We will have a special session later at the conference on Thursday, 13, from 9 to 11. It will be a satellite session. And for now, I really would like to thank you. Together, we will win. Glory to Ukraine.
Thank you so much for sharing your thoughts with us in such an important topic. Thank you so much. Dr. Meg Doherty, World Health Organization, Geneva, Switzerland. The rest of the time is yours. So in much of the discourse about migrant health in urban settings, we lean towards the physical aspects because they are the easiest, more straightforward, and most understood. But how do we define and advance a holistic response to migrant health, especially in multilinguistic and multicultural settings typical of the city? And also, I would like to ask you, what does the World Health Organization advocate regarding how we tend to the whole person needs of migrant populations to optimize HIV and other health outcomes?
Well, thank you very much. I hope you can hear me well. And it's always very difficult to come at the very end of an inspiring panel and also have to find something that's new to say. And it's also quite hard to follow our colleague, Andre, who we know is going through so much. And I would just have to say, we're very, very aware of the challenges and struggles in Europe and very, very supportive. So from the perspective of WHO, and also I want to make sure I thank José Zuniga and the entire team here, because over the years we've found these meetings to become more and more important and specific and addressing those challenges that are really going to help us get to our targets. Meaning that we're not staying at a high level, we're digging deep into what are the specific challenges in cities, in countries, and addressing all of those barriers and not being afraid to talk about the structural barriers and the other barriers that hold us back from reaching our targets. So thank you there. From WHO, we take a global perspective, and as I was preparing, I was also amazed that I didn't know this statistic right now. But right now, WHO is estimating that we have 1 billion migrants globally. 1 in 8 people in the world are not where they originally started. Either they are internally displaced migrants, forcibly displaced, and we heard this from our colleague in Jamaica. And we know that there may be many, many more people who are simply stateless, who don't have a country. And so they are among the most vulnerable persons around, and we've heard this before, and they are a priority of our Director General. So much of a priority that he has developed 2 years ago, right at the cusp of COVID, he developed a new program on health and migration. And essentially from that perspective, the WHO has been looking at opportunities for a cross-cutting response for migrants. And it's health and migration, it's not just health. And I think that's the question you were asking, and this is what we heard from our colleague Andre, that when somebody comes and asks for a condom or they ask for ARVs, there are a whole other set of needs that they have. And we need to be able to address those needs directly. And when WHO speaks about person-centered care, sometimes it sounds like a slogan. And but that's exactly what it means. That when somebody comes to a point of care, whether it's social services, a migrant location, a health center, a quaternary care hospital, that they're not just provided with one single element, that they're provided with a holistic approach to care. That includes physical health care, mental health care, as well as the social services that bind all of us. And we know oftentimes when we're under stress that we address the most urgent, which might be the bleeding wound, but there's so many other things that need to be addressed: the post-traumatic stress disorder, the isolation, the depression, the lack of food. So from WHO's perspective, we put out a new report this year and have a new global plan on promoting health in refugees and migrants up until 2023. I wish we could ask them to take it to 2030 because it's going to be a problem from now on. And in this report, they highlighted good practices and safeguards for that holistic person-centered care. And they called on partners to promote and protect refugees and migrants. Number one thing they asked is look at the root causes of disease that often are outside the health domain, and we've heard about it in clear perspective today. Reorient the health systems to include integrated, inclusive health services for refugees and migrants, and raise public awareness. And I think that's what we're doing here, is we're saying in cities, you can be the motivator, you can raise the public awareness, and you can have treatment in an equal and equity-based approach, and also promote quality research, quality care. So to be honest, just yesterday I asked one of my colleagues to join a new program to be able to look at what are the research gaps, what are the guidelines that need to be done so that WHO can take this more specifically onwards. I wanted to end because I felt like this morning was such a great set of examples that brought the person closer to us and of what we do rather than just what we're saying. And I just spoke this morning with my colleague who's sitting there in the front row, Dr. Slava, who's working in Belarus, and gave me an example that when the migrants came to Belarus, they made sure that they had a primary care nurse or doctor who greeted all. They learned their lessons and they learned their languages, They made sure that they could speak in the local language, that they could understand the problems in the migrant camp. And it wasn't just about the primary care, it was about ensuring that any kind of specialized care were addressed. If they had any issues with mental health, that these were addressed. They had packages of medicines for NCDs as well as ARVs. And I think those are the kinds of approaches that need to be taken globally. And I think at this point, you know, the UN can work, but it's also, as we heard, that we need to have the UN bringing the standards at certain times, procuring items at certain times, but allowing communities and those who know them deliver. And that's where you're going to get that delivery of person-centered holistic care. I wanted to give one last example because of the mayor of Jamaica Jamaica, but also of Botswana brought this up. We have a program called the Global Validation of Elimination of AIDS, or vertical transmission between mothers and children, as well as for HIV, syphilis, and now hepatitis B. And we congratulated Botswana on being the first country in Africa to move onto the silver tier. But our examples always in this validation of the elimination of an infection, and we have to give kudos to Amsterdam to getting to zero and wanting to get to zero, is you can do you can work on the number, meaning the cases, the new infections, the deaths, reducing those, but you also have to do it while addressing the community engagement, the human rights aspects as well. And what we've seen so much so is countries that are struggling to eliminate HIV and mother-to-child transmission, the most often problems we're seeing in getting to that criteria and that tier is the issues of migration and the issues of infections migrating in, migrating out, but there are people associated with those infections. And that's where we have to really see a global world that we can't just eliminate in one city. We have to really work on eliminating everywhere, every place, to be able to end AIDS by 2030. So with this, I want to just say thank you. WHO is really pleased to be here, and I think I've made it within time to give you adequate time for closure, so thank you.
Thank you so much. So I'd like to thank you, to our panelists from session 1, for their powerful interventions on a variety of topics related to migrant health. Thank you so much. I think your insights define some of the challenges that we are facing, but also opportunities for action at both political and public health level. So thank you so much. And of course, thank you for being so brief that we are absolutely in time. Thank you.
Yeah, swap in.
With all due my respect.
Yeah, thank you.
Sí. Good morning. Thank you so much. Hola, buenos días. Muy bien, ¿y usted? Deeper into the topic by welcoming the last session panelists. Some of them are going to be virtual, but we have here so many people to share their ideas. Of course, as in the first panel, many ideas with a global perspective on this topic. And also, before we continue, I would like to thank the organization of the Fast Track Cities 2022, and of course, Sevilla, and of course, the panelists, and you, because you are here listening all of the thoughts and sharing your ideas. So, let me please introduce next panelist, Mr. Wyland Dipo, Mayor of Blantyre, Malawi, Mr. Issa Malam Salatu, Deputy Mayor of Libreville, Gabon, Maria Josefina Belmonte, Mayor of Quezon City, Philippines, We're going to have virtual Mr. Andy Brown, County Judge of Texas, virtual to Robert Ndugwa from the United Nations Human Settlements Program. We are going to have also Dr. Luchika Ditu, virtual, and Mr. Carrie James from the World Hepatitis Alliance in London, in UK. Thank you all for being here. So I think we can start with Mr. Wailendipo, Mayor of Blantyre, Malawi. In these times of budget constraint funding to deliver optimal HIV and other health and social support services to constituent and city and municipal levels is overstretched. So in that context, how do we balance the need to improve and increase health infrastructure and, of course, health workforce for migrants and displaced people while managing dramatic rises in health budgets that obviously affect the entire population?
Thank you for the question. Actually, I think first of all, greetings from the Blantyre city in Malawi to everybody in here. Actually, the goal of HIV/AIDS response is to reach the 2030 strategy. That is, by 2030, we should have no AIDS, or rather, AIDS should not be a threat, or rather to everybody, not only in Malawi, but also, I think, globally. We can only achieve this, I'm sure, by leaving no one behind. Everybody has to be taken on board in such a way, I'm sure, will actually reach where we would want to reach. So in that regard, there must be an enhanced coordination in all those partners that are in HIV/AIDS programs. In fact, we should not work in isolation, because actually we'll be working for a common goal. For example, if maybe A is doing different B, it will be like competing in such a way that then we will not achieve maybe what we are looking for globally else. Okay. The City Council has achieved this actually by doing the mapping of all those partners that are doing the work of HIV/AIDS, and in such a way, we've brought everybody on board, including the vulnerable, and also those that practice health care or whatever you do in terms of what HIV is. And also, as municipal council, being the mayor, we've mainstreamed the HIV program in our programming, and by making sure that politically there is that will and commitment also to the HIV/AIDS. Thereby then, I'm sure, we'll reach out to the rest of the people that are within Blantyre. But much as we have challenges, yes, we should not actually look at the challenges as barrier. We need to move forward. We make sure that we actually re-energize, make a commitment, new commitments, so that the challenges that are there, but we should make sure there's optimal actually service delivery to make sure we achieve this. In fact, Malawi, Blantyre as a city, we are in the pathway from Mozambique. They pass from the other part of Mozambique to the other end. In that way, we have migrants, we have people passing through Blantyre time and again. And we have actually brought them actually on board also. Our systems are not in a way that we put those people maybe outside our systems. No, be it health care or whatever you might call it. we are always with them. And some of them are displaced maybe because of some calamities. You find people maybe are displaced from some areas to the city. Those are also put on the programs that they should not be left behind. Our aim is to make sure that by 2025, as Global is saying, we should also achieve the 95-95-95. In such a way, I'm sure AIDS shall not be a national threat as it is. We've managed as Blantyre to reduce the prevalence rate, I think, from 17.5 to 15.3, something like that %, whereby I'm sure we are moving. But the most importantly is inclusiveness. That is the most thing that actually is putting us maybe on that situation. We have demonstrated our commitment by also developing the strategy, or rather, that is bringing people from all over the city, all over the country, to one situation directly. And however, advocacy is what is also putting us at a better situation, because we are making sure that everybody, the vulnerable, the migrants, whoever, are taken on board. Much as also we are looking at getting funding locally, we are quite sure that, yes, we are doing, and we are actually in a better situation of the same, but I'm hoping that there's continuity might be there, but the fast track also should not leave us behind. I think we are not in a situation that we can actually be standalone as it is now, because this is a national issue that also not only Blantyre is handling this, but maybe it's going beyond Blantyre. City Council has achieved this also by making sure that we map everything, like I said, including partners. But more importantly, I would say that despite whatever is happening, we are moving forward. We should not tie up. We should make new commitments and make sure that there is optimal health service delivery. Thank you so much.
Thank you very much for your ideas and your speech. Mr. Issa Malam Salatu, Deputy Mayor from Libreville, Gabon, thank you for being here. So much of healthcare, especially when it relates to HIV, involves a long-term, if not lifelong, process. Yet much of the discourse regarding migrants sees their health needs as temporary, if at all. So how do we change the political dynamics so that cities, and indeed countries, take a long-term view of how to address the challenge of migrant health that are contributing, of course, to negative individual and population-level health outcomes?
Merci pour.
Thank you very much for your question. And before I start, I would like to thank the organizers of this seminar for having invited us to participate. I would like to honor the mayor of my city. I'm speaking on her behalf. Regarding my country, we can say that our president, Ali Bongo, has endeavored to fight against the plague of we are fighting against, creating in each capital of the province mandatory treatment centers. Please remember that in Gabon, the distribution of antiretroviral drugs is free of charge for our citizens, thanks to our national government. And in order to answer your question, I would like to remind you all that the Libreville, we have a proximity health program with awareness-raising campaigns and primary health care services. In 2016, within the framework of this very same meeting, we signed an agreement with UNAIDS, which was renewed in 2022 with a protocol of agreement. And in order to answer your question, I would also like to point out that the City Council of Libreville has integrated in its management strategy all aspects related to sustainable development in general, and in particular for the population, for the most vulnerable population, healthcare. And we are not leaving behind migrants in these community projects, of course, thanks to the integration of institutional policies and the management of migrants. The City Council of Libreville offers a community health program which will be targeted to all vulnerable segments, migrants, children, and any other layer of Libreville citizens, offering them vaccination programs, healthcare prevention programs, as well as other overall healthcare issues. The migrants' ill health is certainly a very serious issue for us, and city councils are often in the first line of the solutions. All the countries that receive migration are very much aware of this problem and its local implications. In our case, we have intervention in healthcare centers aimed at guaranteeing healthcare at the municipal level, at the national level, or also by NGOs. The problem is sometimes more sensitive when we have more severe cases of AIDS or other chronic pathologies which need, which of course were there before the migrants arrived, or they can appear when they are with us. In this case, the City Council must support migrants, be with them, and we guarantee their health care in our city through our local and national healthcare infrastructures. In Gabon, we have an AIDS and TB program at the national level, and in Gabon, the law gives migrants and refugees the possibility to receive healthcare coverage, which is universal for them. So migrants in my country can go to health centers and they have a health insurance which guarantees their healthcare. However, the problem is for migrants who are not documented or non-acknowledged migrants. So we must promote good practices and support the legal framework so that all migrants have a coverage regardless of their status. And I would also like to point out that data related to migration and health in the framework of the 2030 goals all data are essential to be able to monitor the progress and of the 2030 goals regarding healthcare in order not to leave anyone behind, regardless of the migrant status. We have renewed our commitment with UNAIDS, and this commitment applies to all regions and cities of Gabon. Our commitment has the goal of putting an end to AIDS in Libreville, in my city, especially treating the root causes and the transmission risks, and we are trying to use AIDS response campaigns to also promote a positive social transformation, to mobilize resources for public health and integrated development of our citizens, and to adapt resources to the real local needs. Mayors in Gabon, in my country, We need to join forces to fight against AIDS and HIV. And before I finish, I would like to say that in Gabon, we have recently left the Commonwealth. Today I've spoken in French, and in the next meetings I will speak in English so that everybody can understand me better, but I wanted to speak French for that reason today.
Miss Josefina Belmonte, Mayor, Quezon City, Philippines. Thank you. Migrants are multiply vulnerable across a spectrum of needs, which places them at much higher risk for adverse health outcomes than the general population, including, of course, in relation to HIV, tuberculosis, and viral hepatitis. How do we provide levels of health, safety, and protection for migrants, especially since so many are employed in the informal sector, also paid by the day with no insurance, no contract, and seemingly no future? Thank you.
Thank you, Madam Chair. So the question of Madam Chair has to do with how do we provide social protection to our most vulnerable migrants. And to put things in context, the Philippines, where Quezon City belongs, is a country with 113 million inhabitants. It's quite a large country. And we have 10 million migrants or overseas Filipinos. And I don't know of any country in the world that does not have a Filipino working in that particular country. Now, of the 10 million, 5 million are already permanent residents in the country that they've migrated to and are working there on a permanent basis. About 5 million are temporary workers. Of the 5 million, about 4 million are under contract, and about 1 million are undocumented or do not have work permits. That is the situation. Now, despite the fact that there seem to be a lot of overseas Filipino workers all over the world, the national government has not been remiss pertaining to its duties to look after the welfare of our overseas Filipino workers or migrants. There are so many national government agencies that are working to make sure that our people are well protected. For example, under the Department of Foreign Affairs, there are so many bilateral agreements that have already been reached amongst the various countries where our people are migrating to make sure that employers look after the needs of our people in terms of, let's say, overtime pay, in terms of paternity or maternity leave. Just like what the other mayors mentioned, they look after the migrants that are in their countries. In our case, our migrants are out of our countries, but we have agencies that look after their needs. In addition to this, health insurance and social insurance, these are mandatory for all of our migrants that travel abroad. They all have to get universal health insurance. They all have to contribute to their social security, and they all even have to contribute so that when they come home, they have a house to live in. We have an Overseas Workers Welfare Association that provides all kinds of benefits, from training to scholarships to children, to all kinds of social safety nets to our migrant workers. But what is very surprising is, despite all of the services that we have at the national government level for our millions of migrant workers outside of our country, only, I think, 53% actually are receiving these benefits. And based on the data, it's not really because they're not educated. 80% of migrant workers that leave our country actually are either high school or college graduates. But the sad thing about the situation is that they are educated, but then they are forced also to take on very elementary occupations. So based on all of the occupations that I've looked at, over 42% of our migrant workers, whether they are college graduates or not, are doing domestic work. And when you do domestic work, chances are you do not have the time to pay your contributions for your health insurance or your social security. You're afraid that your employer will not, will take you out of your job if you spend too much time on your personal health needs. So health-seeking behavior is really very, very low in this particular sector. But that is not to say that the service is not there for them. So what we have done in Quezon City is to put up a migrant resource center in our own city. And this center is created by ordinance of the City Council, and its objective is to fill the gaps that the national government seems to be having problems with. So what we now have done, since we are the largest city in the Philippines and probably the biggest source of migrant labor, is we have already put together a database of all of our migrant workers in Quezon City. Not just the migrant workers, but very important to us is the children and the families of these migrant workers. And we have organized these migrant workers into different associations, because in the Philippines, we love to be in associations. We work better when we're associated in various groups. So the community now takes over, and the community now looks after one another's needs. And because of this particular strategy of ours, we are able to keep track of the different problems encountered by our people. So in addition to, and I'll just give you some of the services that we provide. So I mentioned that the national government already provides all these services, but very few are able to avail. So when they come home in Quezon City, we pick them up, and automatically, if they've been displaced, for example, by COVID, and we've had 800,000 all over the Philippines displaced by COVID, automatically we help them find a job. Number two, we help them we provide them with capital assistance so that they can start a business. And while they're looking for a job, if there are some weeks when they have no income, we provide them with financial assistance to tide them over and tide their families over. We also provide scholarships for their children. If they have children who are PWDs, we assist these children. If they have wives who would like to also be part of the workforce or receive capital assistance, we provide this. So these are things that we're able to give to our people at the local level. Now, one of the things that I would like to stress in response to your question about how do we look after the welfare of those in the lowest rung of the occupational ladder in other countries. We have something called the kamustahan. So what is the kamustahan? Here, everyone is virtually enrolled, and we see how they are inside virtually, because everybody from the Philippines has a gadget. We have a tablet, we have a phone. In fact, it's a misplaced way of I guess it's misplaced values in a sense, because people like to spend on gadgets, but it helps in keeping in touch with one another. So through these gadgets, even inside, in the countries where they work, we in the city are able to monitor how they are doing. Whether they're undocumented or not, we can tell if they are okay, if they need health needs, if they need attention, if their children need attention. And we have partnered with so many, not only government agencies, but also non-profit or NGOs, such as the International Labour Organization, such as the UN Women, such as the International Organization for Migrants, and many other NGOs. And when we see that some of our people outside of our country working in the most deplorable situations are distressed, we are able to refer them right away to the NGOs that can help them. So that is something that we developed in Quezon City to help our migrant workers cope. And I guess that's all I'd like to say. There's much more I can say, but I think that's enough. Thank you.
Thank you so much. Now is Mr. Andy Brown's turn. He couldn't be here, but of course he wanted to join the Congress. So my question for him is in relation to urban planning, provision of new housing in an impoverished area of a city is rarely matched with a growth in user-friendly referral services for housing, or even with equitable enforcement of fair housing practices, particularly, of course, for migrants. So how do we tackle this challenge, which is a social determinant of health, has a direct effect on migrant health? And also, who needs to be the decision maker in mass urban planning projects? And of course, how do we address the talent in communities already struggling with housing scarcities?
This is Travis County Judge Andy Brown here in Austin, Texas, and just want to say thanks for having me address this panel about ways we can kind of tackle urban responses to public health emergencies and housing, and some of examples of what we've done here in Travis County. I think if we're going to have a more equitable approach to healthcare and housing in our communities, we really need to have an honest conversation with everyone about achievable solutions and how we can get there. So I came into office about 2 years ago. It was November of 2020, right before COVID vaccines became available in the United States, but the pandemic was raging. I asked our local officials, another county judge in Harris County, kind of what the plan was to get out vaccines in a mass vaccination scale to the most vulnerable people in our community, and frankly, there really wasn't much of a plan. They were hoping to do it through existing doctors' offices and pharmacies. But when you look at a map of Travis County, you see that the doctor's offices and pharmacies are generally in the wealthier part of the county, and there are way fewer in the higher minority, lower income part of the county, which frankly also houses the majority of our essential workers, people who drive buses, teach at schools, work in restaurants, jobs that could not be done as easily remotely. So under this plan, the plan that they had before I came into office, the most vulnerable and hardest hit by COVID were frankly going to be left behind in the vaccination process. So I reached out to neighboring counties. I'm a Democrat here in Texas. There is a Republican right next door, so I reached out to that county judge, another Republican just down south, and then another Democrat, because I knew that at the state level they would frankly listen to me a little bit more if I had some support from a Republican peer. We ended up writing a letter to the state government asking for additional vaccines. They gave us an additional amount for 1 weekend, and we set up the largest non-FEMA mass vaccination site in Texas, which was at the Formula One racetrack. It was called Circuit of the Americas. And we had over 3,000 local volunteers that worked at our clinics. We saved a lot of lives. And because of our focused effort on creating an equitable COVID vaccine response, people were more than 6 times more likely to die from COVID in Texas at large than they were here in Travis County. And if the state of Texas had done the same work and had the same results as we had here in Travis County, there would be another 40,000 people alive in Texas today. 70% of the Travis County vaccine efforts and vaccines have gone to the Latino or Hispanic community, compared with about 30% of efforts, other efforts in the community. So what we learned from our COVID effort is that when we come together with diverse partners for a common purpose and frankly put aside partisan differences and focus on these higher risk communities, we can really make an impact if we're intentional and focused and kind of put the partisanship aside. One of the biggest lessons that COVID taught us here in Travis County is that we really need to remove barriers to providing health care for people in need. Addressing the number of people without proper access to mental health care continues to be my top priority. Before COVID, we had about 20% of the people in jail who had some kind of mental health need that was unmet. By that same measure, that number is about 42% for the jail population and about 60% for women who are in our jail. And so it has increased dramatically. The people in our jail, which is the largest single line item of our county budget, the mental health needs in there are growing, and frankly, it's the largest mental health facility in Travis County, just like it is in most counties in Texas. That's the county jail. That's just not how it should be. So we're working on solutions to implement ways to divert people away from jail who really need mental health access or substance use disorder access or other care that we can provide, and trying to provide access to that care instead of jail. Our community is safer when people have access to safe and stable housing, good jobs, and access to health care, regardless of immigration status. There's several ways that we can help, like utility assistance, home repair assistance, eviction prevention, and rent or mortgage assistance. And those are things that we do at the county level. When we make decisions about development policies, the county needs to hear more from the people that it will impact the most. And so that means creating and investing in programs that don't have immigration status barriers. That means having staff who can fluently read, speak, and write in different languages to help immigrants feel welcome here in Austin and Travis County and improve access to housing programs. Some of the things that we are doing as solutions to the housing need is that we invested half of our ARPA funding. So this is money from the federal government that came to help us recover after COVID. We've put 110 million of that, which is a little less than half, into building more than 2,000 affordable housing units for people who are housing insecure or people at risk of experiencing homelessness. And we made these recommendations after hearing from folks in community-based organizations. Excuse me, good thing we're not in person. From people with past experiences with homelessness or housing insecurity. So these solutions need to also include local dollars and flexible policies. Federal funding does seem to come with more hurdles, more requirements. Many of it has good reasons, but it is harder to implement sometimes the use of those federal dollars. So we need to be ideally more flexible and more creative in the ways that the federal government allows us to use federal dollars. And frankly, as a local government, we need to learn more about the requirements of how to use federal dollars, because that amazing amount of money that we got from the feds, $230, $240 million, is something new to us in that scale. So getting people equitable access to healthcare and housing, even in our communities, is not obviously just a challenge in Austin or Travis County or even in Texas. It's a global issue. It reflects the constant need to find solutions to serve our most vulnerable populations. And we've taken steps here in Travis County, but there's still a lot of work that we have to do over the next several years. As an elected official, I feel it is my job to care for people, the people that we represent, to look out for their health and safety and improve on the health and safety of people in my community. And if our constituents, if the people who live here in Austin and Travis County are struggling for basic needs, how does that impact other parts of government? How does that impact our local economy and ultimately our lives? So lots of challenges locally, but I just got to say that I absolutely love local government. So I'm at the level, there's the city level below us, I'm at the county level, and then the state is above us. And although I'm elected I'm a Democrat, I have a partisan label, I still think at the county level across Texas, there's more opportunities to work across party lines, because you see the results of your budget expenditures almost immediately. You hear from constituents if what you're doing is not working. And so I'm so excited to have these challenges and to have the resources and the partnerships that we need, I think, to address these challenges, to add more wraparound and supportive housing in our community, to add more mental health access in our community, to add more substance use disorder access in our community. And I think that's how we're going to make this a safer and more prosperous community. So thank you so much for your time. Thank you for including me on this. Sorry about sneezing halfway through, but I hope that the conference is good, and I hope that we can do this in person next year. Would love to be there in person next year, and definitely if you end up in Austin and Travis County, please give me a call. I'd love to connect. Thank you so much.
Thank you so much for being with us virtually. And I would like to introduce now to Dr. Robert Ndugwa from the United Nations Human Settlements Program from Nairobi, Kenya. Evidence shows that in countries facing recurrent crises and disasters, city dwellers, including, of course, migrants, head to slum and informal settlements to live with extended family members, drawing on poorly run and understocked health facilities. As a result of this type of migration, is a rise in communicable and non-communicable disease, for example, cholera, outbreaks and spikes in HIV infection. So how and where can we address this concern?
Thank you, Chair, and good morning and good afternoon to you all. It's a privilege, of course, and an honor for the invitation for UN Habitat to participate in today's high-level panel. And it's a very interesting question that you've put forward, but I think it's also important to set a little bit of the context of how we see the unraveling of the urbanization process amidst a high rise of the challenge of migration. So from UN Habitat, we see migration as a force that is very core to the process of urbanization. And we see this, of course, in many ways, as many speakers have said, but also from the urban side, we see that today cities are home to more than half of the world's population. And we expect that figure to be about 66% by 2050. So without any doubt, we know that the movements, the migrations of all these large populations poses very much a variety of challenges, both to big cities, but also smaller towns. But at the same time, we also see migration and perhaps also displacement as opportunities that can boost productivity, but also enhance the local economic development, as we heard from the story from Texas. But also, they play a very key role in terms of strengthening the urban, rural, and economic and social linkages. From the many numbers that we've looked at, we see that for example, the total number of international migrants in 2020 alone was estimated to be around 281 million. But of course, amongst all this, there was about 82 million that were a result of forcibly displaced migrants due to either conflict or violence in their regions or countries. The most recent conflict in Ukraine, as we've heard, has also pushed nearly 14 million people out of their places of origin, both within Ukraine, but also beyond the country's borders. So as cities or as urban areas become very much the first option for a lot of these migrants, basically cities are the first destination of many of these migrants. We see that, for example, 60% of refugees worldwide and 80% of internally displaced persons, they tend to go and settle in either a city or a small town or in general just an urban area. But of course, that is just one force to study quite well. But on the other hand, we also see all the other climatic changes bringing into additional forces in terms of driving displacements, but also increasing the vulnerability of those who are already forced to flee. For example, at the end of 2020, around 7 million people in 104 countries and territories were living in displacement as the result of disasters that happened not only in 2020, but so many years going back. So what we see in this pattern, of course, is that urban migration and health here are increasingly becoming global concerns, but with a lot of significant positive as well as negative impacts, both on the spatial formations of our urban areas, but also the environmental impacts that are emerging, and at the same time, even the socio-economic urban transformations that are desired in all these urban areas. So while many cities, as we've heard today, have, for example, embraced migration as a force that is key for driving their local economic development, in many cases, these increased inflows have also exacerbated competition, not only over health, but also many other opportunities, such as jobs, but also access to other public goods, such as water, housing specifically, but also education, but also aspects of security. And many of these, of course, lead often to enhancing the urban inequalities and vulnerabilities that we see amongst all these populations. So in much of the developing world, we tend also to see this coming out, particularly in terms of the housing vulnerabilities, where a large population of these migrants and internally displaced persons tend to move into slums or informal settlements. Why? Because these areas offer cheap housing for first-time city dwellers, but a lot of this also then increases the vulnerabilities and a lot of the worsening health outcomes that we see amongst all these cities. So the key question then is, what should we do? Already from the slums population that we see, about 1.1 billion people already live in slums or informal settlements across the globe. And this has very huge implication when it comes to health, but also the human rights of those people in terms of all the services they need to enjoy an urban well-being. So we feel there's a lot that can be done, and I think a lot has been said, but I'll just push a little bit more on some of those elements that we need to take care of. First, I think we've gotten a good understanding of the push factors, particularly for migration, and how that can also curtail the processes of integration within the urban policies, the governance, and the financing. So I feel very strongly that having understood such push factors, there's a lot we can do to ensure that our revised urban policies, our governance systems, but also our financing models can at least address a lot of the needs of these migrants and internally displaced persons in a way that is more accommodative for these populations, but also in a way that takes care of the aspects of the entire process and not only focusing on the outcome of migrants being in your city, but actually looking at the entire chain of where they come from, how they move, and how they actually settle down in your cities. As we also heard from the previous speakers, I think it's very important to pay attention to the local response strategies or even the action plans, and particularly in making sure that these are well designed to respond to the entire health needs associated with the migration process, and at the same time offer solutions that are basically very much aligned with the challenges. And I think here, what is important is to understand that slum populations or those informal settlements are basically a manifestation of the failures of many policies and actions by governments. And of course, in one way, if that can be addressed through those local response strategies, this will be very important. The other strategy that I also feel that is very important to ensure the success of all this process for migration, particularly in urban areas, is to ensure that our own strategies take care of the aspect of the availability, the accessibility, but also the acceptability and affordability, and more specifically the quality of the services that we offer to such populations. And here, of course, touching very much on, for example, the quality of health or the social services, but also the other basic services such as water and sanitation. There's also need to pay attention to the need to look at the vulnerabilities to health risks. And as we've heard, a lot of these new migrants tend to settle into areas that are, of course, predominantly already high-risk areas in terms of exposure to potential hazards, but also stress, and at the same time, areas that might increase their susceptibility to poverty, but also social inclusion. So it's important that when we are working on all these strategies, we try and address those vulnerabilities to ensure that we reduce the stigma, but also the discrimination that we see amongst these special populations. I also feel there is a need to focus a little bit more on the various priority areas in all these strategies in a way that we need to be able to implement specific country strategies, but also city strategies that are very suitable to those contexts. You won't be able to pull one strategy from one city and feel it's going to work for another city. So the idea of specificity and context is very important, particularly in terms of aligning with the national legislation, but also the priorities and circumstances that play out in those countries. Last but not least, I also feel that, yes, we've done very good work to understand where these populations are in terms of the data that we've been collecting. But of course, we need to understand even more in detail who is being left behind, where, when, and how. And I think migration and urban health data is very key here to help us understand both the number of migrants affected, but also the nature, the living conditions, and the urban environment in which they live, but also the opportunities or the contributions that come out of all these populations, so that it can, in a holistic way, contribute to a better quality of life, both for the new settlers, but also for the host populations. Thanks a lot.
Thank you very much. Now let's go briefly with Dr. Lutzika Ditiu, Stop TB Partnership, Geneva, Switzerland. I would like to ask you, it is quite difficult for migrants infected with tuberculosis to utilize referral systems, often facing financial hardship and also negotiating a foreign health system and in need of translation skills. Should we focus on bringing medicine to the migrant and not vice versa as at present, and a new genre of decentralized health services for tuberculosis and other diseases?
Yeah, thank you so much. First of all, thank you for bearing with us. I imagine, I don't see the room, but I don't know how many people are still with us here. But those that are, I'm really impressed that you still enjoy listening to us, especially us being online. I understand it's not that easy. I want to thank very much to Jose and the entire team of the Fast Track City and the IAPAC for continuing these events and for including me and my colleagues from my team representing Stop TB Partnership, or to be more concrete, the TB community in these events. I listened to the previous panel speakers and to the colleagues there, and I want to make 3 points. I want to make an overarching point on the fact that you see, you all working on HIV/AIDS for many years benefited in a way of a lot of understanding, a lot of political leadership, a lot of high-level commitment, and a lot of visibility, given by the fact that the HIV drama started not many years ago, 30 years ago, 40 years ago, and captured a lot of the attention and the interest of people, and therefore HIV is pretty well located on the agenda at country level, at regional and the global level. Through a paradoxical situation, TB that is there for longer than HIV/AIDS, it's also an airborne disease, but probably because of the way that was addressed, being perceived as a very medical disease, it's not that much, didn't generate that much of the attention. It's just in the recent years that I think we are penetrating through the walls of understanding the fact that there is absolutely none of the SDGs health targets that we will achieve without properly addressing tuberculosis. As you all know very well, TB still kills 1 in 3 people living with HIV/AIDS. So without properly putting things in place that can address as well TB, targets, especially in African region where the co-infection rates are very high, will not be achieved on HIV or on TB without each other. But more than that, also the targets on nutrition, because 20% of TB is due to malnutrition, both on infection rates as well as on the disease. Also the targets of UNICEF in terms of children with TB, as we have 700 children every day dying of TB, as well as the poverty, as well as. So where I'm trying to go is that and this is my second point, which already starts addressing the question of you, Madam Moderator, is that as Andre brought to us here, the realities in which we all live, the realities in which we also had a few weeks ago the Global Fund replenishment, the realities in which the socio-economic situation and the way in which the governments are looking at investments outside their borders or protecting their national interests are in a way, or in many ways, affecting the way in which the funding comes, in which the targets are set, in which the attention is given. And us in health are basically, and all of you here, mainly mayors, but also UN organizations and other organizations, we are repeating agenda with a lot of other things on the plates of decision makers. So that's why we cannot do too much unless we do it together. So my plea here, which was very much similar, I think, last year, is on trying to do some of these things together and better. And one of them is what you said. COVID showed us that can be suddenly becoming very difficult to access services overnight, more or less. We cannot move out, we cannot go closer, or in the case that we discussed here, and several mayors here, and my previous speaker spoke, and as well as Meg and Iman spoke about the migrants or the vulnerable groups. When you have a vulnerability, you rightly said, Madam Moderator, it's very difficult to get to be diagnosed, to be treated, to be enrolled, to be followed up. And in TB especially, these barriers to access the health services are very, are having a huge impact, because it's not just the individual suffering, it's the fact that the more a person that is having TB and is coughing, the more is delaying the diagnosis, the more people around are getting infected and sick. Leave aside the very bad prognostic of the disease itself, because TB is airborne. And during COVID, we saw not only that it's very difficult to access the services, but also because the TB services were the first ones to get into COVID response due to the type of hospital infection control measures, the flow of patients, laboratory and diagnosing tools. Even if you were able to go, let's say, to move around, you arrive at a hospital that because of COVID or a dispensary was completely relocated, 0 beds for TB, 0 staff for TB. So then you are really more or less going back. So that's why a lot of thinking we put there, but not us. It actually came a lot from the countries. The first one was India. In looking over a bidirectional testing, first of all, like you get somebody that has symptoms of COVID, why don't you do TB? But similarly, you can do other diseases. So basically, you get somebody that has symptoms of one of the infectious diseases. Can we try and get the person diagnosed and tested to screen out other diseases? And to do it in such a way that is becoming much easier for people to access it. You know, bring, as you said, diagnosis at the front door. I think most of us are having a sort of procrastination or laziness. I think I read in a study that that's the human nature of not running. Most of people are not the ones running right away to a doctor. For whatever reason, we have a tendency to delay. Leave aside the fact that we have a vulnerability on top of that. So that's why what we promote through an initiative that we launched several years ago is reimagining the TB care, which is actually reimagining the healthcare, if you want to say. And we are going into having actually conversations with communities and people at country level that are led by people that are not necessarily health people, are people that are developing products that are incorporating what we as individuals prefer to have and where do we want to see this type of services received. But before we end up with all this philosophy, what we are having are a lot of a push for diagnosis, for example, to be multiplexing, to have, for example, either a little van or a structure that is mobile that has several diagnosis tools placed in one location. In one van, for example, you can diagnose for sure HIV, TB, you can do for sure malaria, you can do electrocardiogram, and recently, because of the digitalization and miniaturization of the tools, as well as artificial intelligence, we can do X-ray, and you can read the X-ray with artificial intelligence, and you can diagnose as well pulmonary cancer or other lung diseases, as well as, obviously, you can do diabetes, you can do eye control, and so on.
Dr. Int'l, thank you so much for your strong words and your speech, but I'm so sorry, but we are running out of time. Thank you so much for your speech and your thoughts, but I think we have to continue with our last panelist. Thank you so much for being with us, but I don't want to finish without asking Mr. Kerry James from the World Hepatitis Alliance about what can we do to convince policymakers of the cost benefit in expanding access to HCV screening, testing, and treatment, as well as harm reduction services for migrant population? And I'm so sorry because you just have a few minutes, but I'm sure your ideas will be perfectly explained in those few minutes. Thank you so much.
Yes, the pressure of being the 14th speaker in a 2-hour plenary is certainly feeling on my shoulders. So thank you all of you for sticking around. So I will try to make this brief, memorable, and worth your time. So I think whenever we start talking about, the cost, is it cost efficient or cost savings around these things, I really have to ask, why are we being asked this, right? So there are stacks and stacks of costed reviews, business plans, research articles that say that providing hepatitis testing and care for is cost effective, is cost savings, but still we get these questions, right? And even if we do, we provide all of the cost saving analysis, the proposals still sit on the desks of finance ministers or health departments and they're still not actioned. So, what's really going on here? Is the discussion around cost effectiveness an enabler to get a program funded, or is it an additional barrier that's being put up in order to delay or really get in the way of hepatitis services or migrant health to be addressed? Because we know that in many parts of the world, hepatitis and migrant health are not vote getters in the political classes, and it does take a certain amount of political courage to stand up and say that we need to be providing these services. Because beyond the financial cost, there is, of course, the human cost And it's not just about dollars and cents, it's about equity and human rights. And I think the more as community-based organizations we can do to make that point, the further that we'll get. The further that we'll get in promoting migrant health. Because this isn't a case of should we use this tablet or that one because this one's 5 cents cheaper. It's about life or death. And there are so many instances of migrants from high prevalence countries who move to another country, and there'll be generations of that family dying from liver cancer before anyone ever thinks that they should test them for viral hepatitis. So this isn't, this is a very serious issue and one that we have to really address seriously. But on a practical point of view, integration is absolutely key, right? Making sure that every contact with migrant communities count. And I think the great work that WHO has done around the integrated strategies, the global health sector strategy and the integrated key population strategies go so far in moving this forward. And I really have to applaud the Global Fund for increasing the amount of support that they have for integrated hepatitis services in their latest information note. And I would just ask you that if you are working in a Global Fund supported country for HIV, please have a look at the information note, see all the new services, all of the new support that's available for hepatitis B and C, and please make the most of it. Because I think, just because you're not aware of hepatitis within migrant populations doesn't mean it's not there. I think the stigma around hepatitis is so crippling that oftentimes they're afraid to speak out. If they're recently displaced, they're afraid to be identified as living with viral hepatitis within camps. But we know that it's there. And a recent, one of our members in Bangladesh did a study with the Rohingya communities, and they found HCV prevalence in pregnant women in the camps at 9%. So I think we need to ask, I think we need to ask the right questions, and I think we need to stop accepting the excuses of policymakers, and I think we really need to act for migrant health and for hepatitis, because hepatitis can't wait. Thank you.
Thank you so much for being so brief, and I also thank each of you for joining us and wish you a successful Fast Track Cities 2022 conference. Thank you so much. Thank you.
Say it enough, it gets ingrained.